Welcome, everyone. We had a quick break after our Latam Elso portion of the Bartlett Legacy 24-hour virtual summit, which was amazing. Thank you for everyone that presented, moderated, and participated. You did such a nice job. We are now transitioning over to the Asia Pacific chapter of ELSO, led by John Fraser. John, if you're able to go on screen and join us, you're welcome to begin anytime. I don't see you yet.
Well, there you are, Christine. All your Christmases came at once. I am, as always, organised within an inch of my life, and any chat of me transitioning is untrue. Listen, what a great honour. Thank you, konnichiwa, annyeonghaseyo, nehomai, to the Asia Pacific chapter of the Bartlett Symposium. I'll just share some slides, if I may. What a wonderful day. Also shouting out to all the Irish, the diaspora, happy St. Patrick's Day. Bob loved the occasional whiskey and the occasional sing-song, so I'm certain we can manage one or both of them here. There we have, you've got my slides, Christine?
Yes, I see them. Yep.
Okay, thank you. Let's just see if we get that working that way. There we are. So I think it would be fair to say today is a wonderful celebration of a wonderful man. I'm really just going to chat at the start and introduce the true talent, and I see the true talent in the shape of Vin Pellegrino is already in line. So Bob's legacy, as we know, isn't just writ large across Asia Pacific, but across the world, and that's what we're concentrating on today. I first met Bob not at this meeting of Lifesavers, which was at the Gold Coast Hospital. These are, for those not from Australia, these are the caps that are Lifesavers, where when you go surfing in Bondi Beach or all the lovely other beaches, and we'd actually run out of money and we couldn't afford gifts for everyone, but we're not English and we wanted to make sure people had a gift. So we created these Lifesaver caps because we truly believed that the Asia Pacific ELSO, first run by Graham McLaren, Chen, myself, and now brilliantly by Shingo, was a society of lifesavers. My first meeting with Bob was not at this, it was in China, and our group went to Beijing, and it was the Beijing AP-ELSO meeting, and we had 14 posters there. And of course, I'd known about this legendary Dr. Bartlett. I'd snuck into a lecture when I was a medical student in the early 1990s and heard the great man speak about partial liquid ventilation. But other than that, I'd just seen him for a distance, and as many of us were, I was in awe. And we put our posters up, we were enjoying Beijing, and then the great man approached. And what we'd done was we'd taken all of our posters from the different walls and put them on one wall in Beijing, and we called it the Great Wall of Brisbane. And Bob came up and he congratulated us and talked to all the junior scientists who were, again, and all asking for autographs. And he talked to us and gave us some questions and asked us exactly where this place Brisbane was and how come all this work was coming. And subsequent to that, he joined our lab and our first ever ECMO transfer with Dan Mullaney. Bob gave advice, sat at the bottom. Many of you have heard the story of the time when my youngest son, Thomas, woke up as a 3-year-old to find an elderly man beside him in the car. And Bob introduced himself to a sleepy 3-year-old toddler and said, "My name's Bob." And Tommy, sucking his thumb, pulled his thumb out and said, "So are you Bob the Builder?" Bob said, "I'm terribly sorry, I'm not Bob the Builder, I'm just Bob Bartlett, but I do build the occasional thing." And Wanda in the front seat just roared peals of laughter, saying how unimpressed the 3-year-old was. But as I dropped off the 3-year-old, who's now 15, this morning, getting ready for this talk, he was saying he was maybe even going to try and listen. So after that, Bob would come to our lab, joined us, and this chap on the right-hand side, I think, sums up Australia and ECMO. This man's a surfer. He had been out in the beautiful surf of the Gold Coast and was noticed to collapse on his board. One of his mates pulled him in from the surf, CPR, and then James Van Earls and the team got him and put him on ECMO. He had a cardiac arrest, and this man recovered entirely to go back surfing. So that's the kind of person Bob was. But Bob's got involved with everyone and everyone, and this is a great meeting we'd had with Bob. Chap with a hat on, many of the Americans would know as Bud Frazier. Bud has done more than 1,000 heart transplants. He's the key chap in Texas Heart Centre. And then to the right-hand side is David McGiffin, who's done more transplants in Australia than the rest of the continent combined. So a wonderful lunch, sharing stories with three giants of the society. But and Bud Fraser's an amazing man. But Bob is quiet, maybe not as surgical like as some of them. This was a wonderful lunch to sit and listen to the people that really changed the way societies worked. We had a marvellous time, and Christine and the team were involved in this. We had a marvellous time going across to Michigan just a couple of years ago. Bob had lost his sight, sadly, by this point, pretty much. And it was a wonderful day of people coming together, talking about the legacies that everyone across the world is talking about today. But the thing Bob was most excited about was his Go Blue and his Michigan band, which came into that wonderful auditorium where he started ELSO over 30 years ago. And the excitement Bob had at seeing his band. We would always hear about Go Blue in Michigan and the football team, even though it's not proper football. It was a wonderful time, and just seeing the people from around the world that would come and appreciate him and Wanda too. I think that's, without Wanda, Bob would have been lost a lot of time. So I think we must also remember her and just sit listening to the stories of yesteryear and how when they started the ECMO circuitry, one of the key components of the ECMO trolley was a pair of toenail clippers, because they would use the bypass cannula without side holes, and they would clip a little hole in the side of the cannula to make it. And this truly is the spirit of innovation. It maybe wouldn't pass go on the ethics committee today, but when the toenail clippers had been used by one of his staff, and I wouldn't name them, clipping his actual toes, one of the ECMO runs was delayed because they had to go and get some sterile toe clippers. So I think my son would talk about Bob the Builder, can he fix it? And again, this was one of our adverts at the APL. So here, this world leader was present, but could always take a joke. And this was Bob the Builder as Bob Bartlett. And I guess the question was, can he fix it? And last year, with the ELSO's experience in Michigan, in Ann Arbor, this was a life well lived and a mission accomplished, and Bob definitely did fix it. So today, ladies and gentlemen, wherever you are in the world, I think it's a case of celebrating not just the brilliance of this man, but the humility of him too, and the fact that yes, he created ECMO, yes, he's the father of this, yes, he saved countless lives, but much, much more than this. He created a global community, all of whom are sitting here today, to join with him and to enjoy what we're trying to achieve across here. So Asia Pacific is a wide, diverse region, as you'll know, and we're going to move on to our first talk. But we're moving between time zones and war zones. But again, despite all these things, Bartlett holds true. And regardless of the politics across the world, we're managing to come together. And if only the politicians could do the same. But again, have a wonderful St. Patrick's Day. I'm going to be joining in and out throughout the day. And we look forward to our first talk, who I believe is sitting on line. And I think that is Sandra Parker. 1 minute to spare.
Hello, everyone.
Let
me just share my slides with you all.
Sandra's just starting. She's one of the postdocs from CCRG looking at complement activation, a big problem, and Bob was very, very keen in this field, and even just before he died, he was talking about some of the things that we had to do. So Sandra, no pressure, but Bartlett is watching. Please continue.
Thank you, John. So as John said, my name is Sandra. I'm one of the new postdocs at CCRG. My background is in biomedical science, so this will be slightly more sciencey than more clinically, but stick with me. So I'll be sort of talking about the last 10 years worth of work looking at ECMO's effect on the blood. And I want to sort of delve into four main topics here. So we've got blood trauma, anticoagulation, obviously incredibly important in ECMO, immuno and then the inflammatory load of ECMO, and also using ECMO as a drug delivery platform. So firstly, we're going to talk about blood trauma. So ECMO is tough on blood. I think we all know this. Complications are extremely common. This is the Excel registry here demonstrating the list of common complications seen in ECMO patients. And the highlighted ones here are complications that are directly linked to blood trauma. And we know that blood trauma worsens ECMO patient outcomes. But what are the factors that contribute to this? So one of the factors that we found actually at CCRG is the flow of the ECMO device itself. So when we look at, we can utilize our ex vivo ECMO model, which essentially is a clinical ECMO unit that we connect together to form a closed loop, and we can prime that system with about 450 ml of healthy fresh human blood. This allows us to test different settings, different medications, all without confounding patient variables and obviously without having to actually test on patients. So when we used this model, we actually found that low flow was actually caused more blood trauma and not less. So low flow caused more hemolysis, more platelet dysfunction, and a higher level of von Willebrand disease. And once we published this, a few other groups around the world started to come forward and ask the question of why is this? It seems extremely counterintuitive. So they actually found that pumps are optimized for a mid-range RPM, and actually below this range, blood spends longer in high shear stress zones inside the pump head. And this was found across all pump heads tested, which included the DP3, Rotaflow, and Revolution pump. And actually at 0.5 liters per minute, the shear exposure time of the blood was up to 5 times longer. There's also this diagram here that indicates the pressure in the head of the pump versus the flow rates for two different pumps, the Rotaflow and the DP3. And the clinical operating ranges are shown in the dashed ellipses here. As we can see, as flow rate decreases, our risk of hemolysis and blood trauma increases. So clinical implication here is if you have to use a low flow rate, we need to minimize circuit resistance. And this matters critically when the flow is low. The second I want to touch on briefly is anticoagulation. Obviously, we know that coagulopathies are incredibly common in ECMO, and there's a bit of a paradox to them, where bleeding and clotting both occur sometimes simultaneously. And this is true for both VV and VA ECMO. So to understand why, we have to really go back to the scientific basics of understanding the coagulation cascade. So we obviously have two pathways that can stimulate a clot. We have the intrinsic and the extrinsic pathways. So the extrinsic pathway is activated by tissue injury, but the intrinsic pathway is one that's important in ECMO because ECMO surfaces can activate factor 12, leading to clot formation. This can cause thrombosis, obviously, that can also cause circuit malfunction and also embolytic events in the patients. But this can actually cause paradoxical bleeding as well because the coagulation factors are actually consumed by that activation, which depletes the system and the patient can't actually clot appropriately where it's needed. Obviously, inflammation also feeds into this coagulopathy, but I will discuss that a bit later. So our current anticoagulation strategies all target downstream of this initial internal pathway activation. So we've got thrombin inhibitors, we've got our unfractionated heparin, bivalirudin, and agatroban that all target thrombin downstream. But what if we addressed this cause? What if we looked at intrinsic pathway activation and modulating that activation in ECMO? So people have actually looked at this, looking at factor 12A inhibition, which targets the factor 12A, which is a key contact activation product produced in ECMO. And using our ex vivo loop, we actually also found that factor 12A inhibition was an effective anticoagulant strategy, and it it leads to the extrinsic pathway being available to the patient so that they can clot appropriately still, which may help address this paradoxical bleeding clotting paradigm that ECMO patients face. Okay, now I'm going to touch very briefly on the inflammatory load that ECMO causes. So ECMO triggers an immediate SIRS-like inflammatory response. Our blood is incredibly good at detecting foreign surfaces. It's one of the main factors of our immune system. We need to be able to quickly detect foreign invaders. Unfortunately, this circuit is not a foreign invader, but our blood cannot tell the difference. So we get immediate contact activation and complement activation, which can cause huge cytokine spikes and essentially activate all of our major immune cells. And actually, going back to the idea of flow, using our ex vivo loop, we actually also found that high flow causes a higher level of inflammatory load in the blood, low flow causing less. So high flow, less blood trauma, but heightened inflammatory load. We don't really have a perfect ECMO setting for blood. Unfortunately, it's going to have to be one of those personalized things where we account for the patient's own risk factors when determining flow settings. And one of the bodies of work that I'm currently looking at is complement activation. So we know complement activation the complement system is a key part of our body's innate immune system. It is our main detector of foreign surfaces. And I'm currently mapping exactly how complement gets activated in an ECMO loop, again, using our ex vivo blood loop model. And what I found is that actually complement is being activated by two pathways simultaneously, and that this actually could drive the SIRS picture that we see in early ECMO and may potentially contribute to vascular disturbances and organ dysfunction later on. Obviously, this is an area that I'm currently actively looking at. So lastly, I briefly want to touch on using ECMO as a drug delivery platform. So I'll use hydrogen therapy as the example here. The problem is inhaled hydrogen is a novel treatment for ARDS. And in mild to moderate ARDS, that works very well. Inhaled hydrogen does help alleviate the pathology of ARDS. However, in severe ARDS, obviously your alveoli are flooded, no gas exchange is possible, and inhaled hydrogen cannot actually reach the site of action where it's needed. So there's actually quite an elegant solution here. We can add hydrogen gas to the sweet gas alongside oxygen. This is very elegant. It can bypass the flooded lungs entirely, and we don't need any new device, simply just a different gas mixture. And again, we went back to our ex vivo blood loop model to test this. Can we achieve stable levels of hydrogen in the blood? And the answer to that was yes. We can achieve these levels very, very quickly, and they stay very stable throughout the 6 hours that we looked at it. We also showed that it can reduce oxidative stress, and it can modulate coagulation and inflammatory cascades. And then we took it to our ARDS sheep model, and when we added it to the sweet gas, what we actually found was we can get stable delivery of that gas, of hydrogen, to virtually every organ system that we looked at. So not only are the levels stable in blood, but the hydrogen is actually getting to the site where it's needed. So this could be a really amazing therapeutic option in ARDS. And I want to thank you all for listening to me today. I know it was quite a lot quick fire, several different topics, but there's a lot of really incredible work going on in the ECMO space at the moment. And I think we'll take questions at the end, but thank you all.
Sandra, thanks very much. Great presentation. Lovely to kick off with the science that we're doing so much work on, and that I know Bob was fascinated by. We're going to move on and take questions at the end, and if you can hang on, that'd be wonderful, Sandra. Alors maintenant, nous allons à Paris. We move on to Paris. A lot of the work we did with a young chap from called Silver Heinzer, who came from Estonia, which, as Bob would always remind us, was the true or scientific origin of ECMO. Silver Heinzer did a lot of work on pulsatility. We saw some great results. Silver won a number of awards and has recently been awarded the top scientist in his whole country of Estonia. To follow Silver's fantastic scientific work, we got our colleagues from France arriving with Quentin Moen, who's now going to talk to us as he translates and rethinking the flow in ECMO. Allons-y, Quentin. I'm not sure if he's on French time or if he is waiting in the wings. Quentin, can you switch your camera on?
Yes, I think it's switched on. Thank you, John.
Yeah.
I'm going to share. Okay. I'm Quentin Moyon. I'm an intensivist from France. I joined CCRG a few months ago as a PhD candidate, and my talk is on pulsatile ECMO. And I usually start with this figure when I need to defend pulsatile ECMO in lay terms. Of course, that's not really necessary for this audience, but it still illustrates the reasoning quite well. First, heart failure is common and severe, which is usually not difficult to agree on. Second, there is a clear discrepancy between the rapidly increasing use of ECMO over the past 15 years and the outcomes, which remain somewhat disappointing in randomized trials. Then, there is a more intuitive idea. Organs have been exposed to pulsatile blood flow for their entire evolutionary history, roughly 500 million years. So it seems reasonable to think that allowing ECMO to generate a pulse could represent a meaningful improvement in the way this device supports the circulation. Intuition is useful, but as Edward Deming used to say, in God we trust, all others must bring data. So the first step is to look at the evidence supporting ECMO in cardiogenic shock. Until recently, it was still possible to rely on the lack of randomized trials to assume that ECMO improves outcome in cardiogenic shock. But over the last 5 years, data have started to accumulate and have challenged this assumption. My point is obviously not to condemn ECMO itself. Methodological limitations clearly explain a large part of the neutral results of these trials, but they should not prevent us from also questioning the device itself and how we use it. This slide shows what pulsatile ECMO claims to improve. Pulsatility may reduce LV afterload and increase coronary flow. It may also improve renal and brain perfusion. Maybe one of the strongest aspects is the microcirculation, where pulsatile flow seems to improve microvascular flow distribution. These are the potential benefits that pulsatile ECMO is expected to provide. To test these assumptions, we started by conducting a series of mock loop experiments. A mock loop is basically a set of tubes, chamber, and pistons that can reproduce cardiac physiology with surprising fidelity. It allows to test different ECMO strategies in a well-controlled environment. Here, I would like to briefly step aside to clarify a few concepts useful to better understand the mock loop experiment. Indeed, we used to think that because ECMO sends blood retrogradely through the aorta, it increases LV afterload and therefore LV preload. But while we can be quite confident about the effect of ECMO in decreasing LV preload and increasing LV afterload, the effect on LV preload is harder to predict because ECMO also reduces RV ejection. Some data suggest that, contrary to what we believed for many years, the PV loop actually shifts to the left with ECMO, and that the wedge pressure could be decreased with higher flow. So going back to our mock loop experiment, we systematically studied the effect of ECMO flow, heart rate, pulse shape, timing, and cannula position on two main outcomes: surplus hemodynamic energy, which relates to organ perfusion, and LV workload, which relates to myocardial recovery. A key point when studying the effect on flow on cardiac workload is to distinguish what is due to flow itself and what is due to pressure. And this is why I briefly stepped aside earlier. For this reason, we kept the mean arterial pressure constant at 65 millimeter of mercury during all the experiments. What is worth noting here is that increasing flow from 2 to 3 liters does not change much the PV loop, whereas going from 3 to 4 liters substantially shifts it to the right. This may seem to contradict what I mentioned earlier, that ECMO may actually decrease LV preload. Our hypothesis is that this reflects a nonlinear effect on ECMO on LV preload. Here you can see the timing of the pulse and that it has a clear impact both on the energy delivered and on the workload imposed to the LV. Depending on when the pulse is generated within the cardiac cycle, the effect can even become detrimental compared with continuous flow. From our experiment, we showed that if the goal is to maximize organ perfusion, the pulse needs to be generated early in systole. In contrast, if the goal is to minimize LV workload, the pulse should be initiated early in diastole. Here you can see the PV loops for the 3 timings we selected. The one that maximize energy in orange, the one that minimize LV workload in blue, and the best compromise in yellow. So in practice, the optimal timings depend on the clinical situation. If the patient is stable and the goal is myocardial recovery, early diastolic pulsation help reduce LV workload. But in the acute phase of cardiogenic shock, when organ perfusion is a priority, early systolic pulsation may enhance surplus hemodynamic energy. We now move from benchtop experiment to animal studies. This is the InSync study, which we are trying to replicate and, if possible, improve. The CCRG previously conducted a randomized experiment in sheep. After inducing cardiogenic shock using ethanol injection into the myocardium, the animals were randomized to 24 hours of continuous or 24 hours of pulsatile ECMO. The primary outcome was microcirculation, more specifically, the perfused vessel density, and it was significantly improved with pulsatile support versus continuous one. Several other microcirculatory markers followed the same direction. However, the InSync study did not fully settle the question because the groups were not perfectly balanced at baseline, because the pulse was not optimized, and because the amplitude generated has since been increased. We are currently conducting a new large animal model with a 48 hours duration that better reflects clinical ECMO. We also chose a crossover design so that each animal serves at its own control, so the variability between animals is no longer driving the results. Finally, maybe the real comparator for pulsatile ECMO is not continuous ECMO alone, but continuous ECMO plus an IABP, which is increasingly becoming the clinical gold standard in the management of cardiogenic shock. So the next phase of our work is to directly compare these strategies, pulsatile ECMO, continuous ECMO, and continuous ECMO combined with IABP. This is a study we are currently building, and we hope it will help clarify when and for whom pulsatility truly matters. Thank you for your attention.
Merci, Quentin. Perfect presentation, building on the work of Dinanth and Silver Dinanth, an engineer from India, Silver, a medic from Estonia who came from very close to where Ted Kolobov came in Tartu. And that was, as Bob Bartlett will tell you, the first man to really work on ECMO. Quentin, I'll get you just to stop sharing your screen, if you wouldn't mind, please. And it's a great pleasure now that we move to Australia's own Bob Bartlett, Vin Pellegrino. So Vin and his boss, Bob Salomonson, really were the people that brought ECMO to Australia. ECMO really kicked off here in swine flu territory, and Vin was basically on call for an entire continent I always don't attribute the brilliance and the outcomes to Vin, but to his brilliant wife, Mon, who would take more phone calls in the bedroom about ECMO than anything else, and she probably knows more than us. So we're going to pass it over now from Brisbane at the top of Australia, academically and geographically, to the bottom of Australia and on to the Alfred. Dr. Pellegrino, good morning.
Good morning, John, and the wider audience. Can I just check you can hear all right?
Perfect.
Yeah. Okay, great. I'll just let me share my screen. So hopefully you have the presentation up before you. Can I just check that's going okay?
Yep, perfect.
Yep. Thanks, buddy. All right. So thank you, John. I see Christine online. Thank you very much. And I very much enjoyed scrolling down the list of participants and seeing so many names that I recognised and hopefully are all tuned in. Thank you for arranging this meeting on behalf of Bob's Legacy and inviting us to contribute. I will just be starting off with an introduction for some of the researchers in our department to follow. But I just set a few minutes aside from our allotted time to talk about Bob's legacy personally, which was quite profound for me. So what I wanted to show you was a timeline that pretty much lines up over 33 years with my medical career. And it's the history of ECMO use at our centre, the Alfred Hospital, which started in 1990 and was, not surprisingly, began a year after it became a heart and lung transplant program for the state. It was the second one nationally, and after starting heart and lung transplantation and taking patients with severe end-stage heart failure, the need for ECMO was recognised, and it was also a period where the Italians were doing extracorporeal support of the lungs, and there was an interest in pursuing that as well. So the journey.
Can I just ask you to put, Ben, can you put your slides on slide presenter mode?
Oh,
please?
I thought I had. I'm so sorry. There you go.
Thank
Yep.
you very much.
And so we started in 1990, and that was the case. Now, what I've done there is just put a series of stepping stones really that I've picked as important from the beginning of when ECMO really was a rather invasive, highly specialized and risky support available to very few people, all the way on that journey to it now being a required and expected therapy that is very safe, that is widely accessible, that is governed and accountable, and has known costs and known outcomes, incorporates very advanced education pathways for the staff involved, and has its own research field, which drives its improvement. And I think that journey has taken 33 years of my career. And I just want to spend a minute or two. I won't be going through each of these points. A lot of the points, the ECPR and the echocardiographic use will be discussed by Vinod, and Aidan will talk a lot about our registry-based research programs, which allow us to do efficient, pragmatic trial designs. And so they'll go there. But I did want to say a few things because this form of ECMO, which began in 1990 and really operated for about 10 to 12 years, was not associated with today's outcomes. Very few patients the minority of patients were able even to survive the ECMO run during that period. And I've just shown 12 years of data of the outcomes of patients during their ECMO run only. And you can see rather than things getting better, things got worse by 2002. This isn't to mitigate against the pioneering and incredible work ethic of the people that brought this support in. And the learnings that were acquired during this phase really set up our program for the next indefinite period of time that I think we have benefited from greatly. So in awe of the people that worked through this program. I in fact came to the hospital in 1998, and so was just there for the latter part of that. But really that brought us to a new way that we would try and bring this service from a bespoke, creative resuscitation tool to a far more protocolized and guideline-driven process. So what we really did was look at bringing ECMO into the ICU as an integrated service that was delivered very much as continuous renal replacement therapy was delivered for our ICU patients. Mechanical ventilation was delivered. It was delivered by medical teams overseeing bedside care by specialised ICU nurses. And that's what we did. This meant we didn't require any additional staffing or staffing costs. And we brought this in at the time we this started in 2003. It was quite an unknown, and it certainly wasn't the way things were done in the rest of the world. So most of the world was still using different circuitry components and very different staffing models to deliver this care. And what I really want to say more than anything today was that when Bob visited in 2010 and saw this in operation, he was incredibly supportive. And I had a photo with he and I in 2010, which I was unable to find, but I'm very grateful I did get this opportunity to speak to him in 2024. John showed that session, and the moment I said, "Hi, Bob," he recognised my voice and asked me to sit down. And he had excellent recollection of that visit and the time he came. He was really supportive of the program and the way we had set up the clinical care service. And I'm forever grateful for that. Now, over the ensuing years, there's been quite a lot of successful milestones from the first ECPR trial done at our centre to the outcomes of the H1N1 to the development of the Excel registry for prospective research to the statewide clinical service that reports its outcomes. These have all been huge developments as we've gone through, and the team that has been keen to work on this has been driven by the belief that we are doing a good thing. And I'm really pleased. I met Bob when I did in 2007. I'm very glad he chose to attend and inspire our service in 2010, 2012, and 2017. And we are forever grateful. So with those few words, I'd like to now introduce Aidan Burrell to take over. I will stop sharing and head back and hand over to Aidan to talk a little bit about the research side and the development of our registry-based trials.
Thanks, Vin, and thanks, Aidan. All yours, mate.
Load up my slides. Thank you, John. Thanks, Vin, for that introduction. And it really gives me great pleasure to present on behalf of many people about the Australian ECMO experience. And I guess, as I've said in the title, it's really from Bob Bartlett, from innovation in the early days that has led to us having a legacy of innovation and research that continues today in Australia. My name's Aidan. I work with Vin at the Alfred Hospital and also work at Monash University at the ANZIC RC. So as we've heard, Bob's legacy is multifaceted. He was a great innovator, a fantastic educator. He had a systems approach and really developed clinical systems. He was a humanist and had a big impact on the human aspect of delivering critical care in ECMO. And he was also a researcher. And some of the earliest case series ever described were led by Bob. In this very first series, he looked at 28 cases of neonatal and adult ECMO. And even in this early description, you can see him searching for populations that are going to benefit and also trying to avoid in populations where there's no benefit. And reading this very old research is actually quite illuminating in how developed he was and the people were even in the late 70s. He led the first pediatric and neonatal randomized controlled trial in 1985. And this trial had many innovations and was well ahead of its time. There were 12 patients, there was one control. They used play the winner sort of outcome methodology. They had adaptive design, well ahead of its time. And it's really now in the last 10 years that some of the same issues have come up. He also identified the problem with doing research in ECMO is it's a rescue procedure, and withholding ECMO in patients who are dying is very difficult with randomized controlled trials. And we've seen this play out over the last 30 years that the same issues continue. In the Australian setting, we have developed more and more of a research program around ECMO. And it really began with this study in 2009, an observational study looking at the institution of VV ECMO in a large number of patients in the winter of 2009 in the Southern Hemisphere. This was a study led by Andrew Davies and a big collaboration of different people. And what it highlighted was how integrated and how pandemics can present in the Southern Hemisphere and very quickly move on to the Northern Hemisphere. And again, preempted what we saw in COVID over the last 5 years. Vin mentioned this, and Vinod's going to talk more, but the second really key study in Australia was the CHEER trial, which was published in 2015. And this was a single centre study at the Alfred in Victoria, looking at the institution of ECPR in out-of-hospital cardiac arrest. And we saw, although the numbers were small, what it showed is a system that worked within the Ambulance Victoria network with coordination and education at site. Incredibly complex, but it showed that it was feasible and possible to do this, and really has seen a huge growth following on from this study in the use of ECMO for cardiac arrest. We recognise, though, over the many years that single centre studies are not really going to be powerful enough to change practice, and work led by Carol and also Vin and many other people went in to develop the binational ECMO registry. And this began in 2019 and is now in its 7th year, and there are over 2,000 patients in the registry. This registry provided an infrastructure for benchmarking, for multi-centre scientific research, and also for us to be able to embed clinical trials and more advanced methodology in order to look at better and more practice-changing research. One of the first things that were developed were looking at ECMO patients systematically, looking at their long-term outcomes. And this is work that Carol led, looking at death or disability at 6 months. And it really showed how, although ECMO is a very powerful device at improving survival, many patients suffer very severe disability for a long time. And that if we want to be serious about improving outcomes for our patients, that longer term outcomes are a key aspect beyond just the very early phase of critical care. We've repeated this now with a 12-month outcome study, and we've just had funding for a 24-month outcome study. And what we're finding is although there is severe disability, improvements do occur, but they occur over 6 months to 12-month periods. And so really longer term studies are essential to look at the overall role of ECMO in our patients. We've developed quite an extensive patient with lived experience consumer group in Australia, and It's just incredible the input and involvement and participation that our consumers are now involving in our research, and also participating and informing what are the important issues for our patients. The Excel infrastructure also allowed us to embed randomized controlled trials, and this study, the blended trial, was published in 2024. It compared a conservative oxygen target of 92 to 96% saturations as compared to a more liberal one where it was 97 to 100%. And we showed that targeting a conservative sort of oxygenation target did not improve outcomes, and in fact was associated with high rates of hypoxic episodes. So this is really where we're looking at advanced study design to inform our practice. This surprised us. We didn't expect this result. And I think this is the type of research that is really thought-provoking and is going to inform practice in the future. Excel has enabled us to embed many studies, and we've had blood studies. We've had another randomized controlled trial of ECMO rehabilitation and transfusion targets. We have a national biomarker and mechanistic study called PRECISE, a randomized controlled trial of early VV ECMO, which is underway amongst 10 sites now, and also the ECMO recovery program, which is just getting started. We've integrated with ELSO and managed to find efficiencies in using Excel as a registry for research and integrating it with ELSO benchmarking, and there's been a really great fruitful relationship there. And then also Index and Recommend, which is our new platform trial. Integral to all of this is our education and training program, which program I went through when I did my PhD, and we have a growing number of people, really the future generation of researchers for us all, leading the way. Finally, this has been a fantastic sounding board for international collaboration, and we collaborate with Index in North America with Eddie Fan. John and Carol now have taken over from Dan Brody and Art Slutsky, the ECMONet, which is dedicated to multi-center research. And it really has been a fantastic growth. And linking it back to Bob, in the end, really research and innovation were integral right from the beginning, and particularly collaborative and high-quality scientific research. And this has really been the springboard for collaborative multi-center research in Australia, a systematic approach, innovative trial design, registries, collaboration, and randomized controlled trials. Finally, the focus Bob had on patients and improving patient outcomes has really been an inspiration for this whole program. So I'd like to thank you all and leave it there. Thanks, John.
Wonderful, and I think, as you say, the fact collaboration was Bob's whole thing. Moving from old man Vin, slightly younger man Aidan, we're going on to Vinod now, who's going to tell us the future. And Vinod's going to talk, I believe, about ECPR and the echo delivery service. Vinod, over to you, please.
Thank you, John. Just want to check whether you are able to see the...
Yeah, if you just switch over to, if you leave it onto slide view, thanks, the slideshow.
Yeah. Can you see the screen now, the slideshow?
It's still, yeah, that's us now, thank you.
Just one final confirmation before I start that you're able to see.
Perfect.
Thank you very much. This presentation is more along the lines of what we have done at the Alfred Hospital over the course of the last 15 years with our ECPR and the echo service delivery. So our journey, ECPR journey, started in 2011, 2012 when we started the CHEER study, which was the pilot study looking at the feasibility of ECPR in our setting. As Aidan and Vin have mentioned, this study was led by Professor Steve Bernard, who's pictured here, and we showed that it was feasible in our setting. And the second study that I've highlighted there is the study which looked at the experience of our first 75 patients, from which we got the main thing that determines the outcome is the arrest to ECMO time. So it was all about how we reduce the time from cardiac arrest to getting the patient on ECMO, which matters for eCPR. So now I'm going to talk about the multiple iterations of changes or the continuous improvement that we have undergone in our center. So when we started doing eCPR, the cannulation principles were essentially based on a normal VA ECMO cannulation principle. So essentially what we realized that it was not possible to put the patients quickly on ECMO if we followed those principles, because it was taking too long to assemble the equipment, and it was there was a lot of confusion about what roles different personnel were playing in that scenario. So this led one of our intensivists at that time, Dr. Richard Lim, to come up with this trolley concept, which had the buckets, which had all the eCPR equipment that were already there for us to just open and start the eCPR. So that reduced our time to eCPR commencement significantly. And the other thing that led for our center to develop was our local guideline, and that guideline was developed using simulation. Using Jason McClure, who's shown here, he actually came up with this concept of using simulation, and we did multiple simulations, and that helped guide our guideline development. And that experience has been reported in this study, which I've highlighted here. The photo on here shows our current eCPR trolley setup, in which we can set up the trolley within 2 minutes. The next came the eCPR inclusion criteria. We had broad eCPR inclusion criteria, but the adherence to that was not that great. Arnie Deal, who's one of our intensivists, who's the current head of ECMO service, actually did an internal audit and showed that we get good outcomes only when we adhere to the inclusion criteria. Whenever we breach the inclusion criteria for putting the patients on ECMO during eCPR, the survival is 0%. So that was a very important lesson for us to learn, that we have to follow the inclusion criteria strictly, otherwise the outcome from eCPR is not going to be great. Before eCPR, we got a brain dead patient once in a while, but after eCPR, because of hypoxemic ischemic injury to the brain, there were patients who developed brain death, and it was at that time, it was not clear how to make the diagnosis of brain death clinically in these patients. That is, how to conduct apnea test on ECMO when the patients are actually getting the CO2 clearance from the ECMO machine. Josh Isle, who's also an organ donation specialist and our previous ECMO head, essentially worked on this and developed our apnea testing guideline on VA ECMO for patients, and which has helped us to certify brain death using clinical parameters at the bedside, and we don't have to transfer the patients to the nuclear medicine lab for confirmatory test anymore as a result of that. And that experience and that guideline is reported in the SIO. One of the main things with eCPR survival is that the patients had to live close to the hospital. They have to be within an hour drive to the hospital for the ambulance paramedics to transfer them to the Alfred Hospital for eCPR. So that reduced the equity of access to all the eCPR patients. So using the modeling study that Sasha Richardson led, we showed that if we use a mobile eCPR service, the 5 million, more than 5 million population living in the metropolitan Melbourne can be covered by the pre-hospital eCPR service. And their experience of the initial patients have been reported, which shows that the survival can go above 30% in patients having out-of-hospital cardiac arrest. So traditionally, the numbers quoted for out-of-hospital cardiac arrest is around 25%. whereas with the pre-hospital eCPR, that can be further increased. The survival can further be increased. So this was another key thing that we have learned in our journey with eCPR. And then came this question of how much are we actually spending on eCPR? Is it worthwhile? What are the long-term outcomes of these patients? Are they all having vegetative state after they survive from eCPR? So we looked at this using a time-driven activity base, which is a bottom-up approach in which we looked at each and every stage of eCPR and then estimated the cost of eCPR. And we also reported our long-term health-related quality of life using the Victorian ambulance cardiac registry data and the Excel registry, in which we showed essentially that the quality of life at 12 months is very similar to that of the average Australian population. Now let me take you a journey with echocardiography. Echocardiography plays a crucial role in the management of ECMO patients, from selection of patients to during their ECMO run and also after their ECMO is decannulated in these patients. A good ECMO service is essential. A good echo service is essential for ECMO. And how did we start our echo journey? It was pioneered at our center by Prof. Andrew Hilton, who essentially developed our initial guidance for cannulation and also the use of ultrasound, particularly the transthoracic echocardiography using subcostal views to guide the cannulation. And this was further developed by Dr. Deirdre Murphy, who was the head of cardiothoracic ICU. Our ICU echo service delivery and guidance for ECMO is based on this levels of training, which is promulgated by the College of Intensive Care Medicine. The basic level is all the intensivists are trained in basic level. They can do subcostal views and guide cannulation at the bedside. Advanced practitioners can do transthoracic, transesophageal, and all the advanced modalities so that they can guide the management of the patients. We have intensivist-led, intensivist reported, and intensivist archiving the images. We looked at our echocardiography use in ECMO, and what we found was that our usage of transesophageal echocardiography for management ECMO is only in about less than 10% of the patients. This is, we predominantly use transthoracic echocardiography for managing the patients in our unit with excellent outcomes. This is in contradiction to some of the other centers which solely use transesophageal echocardiography based on the belief that it provides the perfect imaging for managing these patients. But however, we showed in our study that transthoracic echocardiography is equally good for managing these patients. And this is our team. I'm blessed to be working with highly intelligent, motivated, and collaborative individuals in our department who essentially manage the patients on ECMO. These are not just echocardiography experts, they are ECMO experts as well. So they can actually be able to manage these patients better. So at the end of the day, as Bob said, it was all about teamwork, collaboration, and continuous improvement that has led the growth of our service, and that's Bob's legacy in our unit. Thank you very much for your patient listening.
Thank you so much. A wonderful presentation. I apologize, I'm not quite sure why we've got an echo here. But anyway, we're going to move on, leaving Melbourne, go to Sydney now. So what we'll do is hear from, I think it's Hergen is going to speak to us from St Vinny's in Sydney, and then we'll take a couple of questions before we jump across the ditch to the Philippines and Greater Asia. So Hergen, if you're ready to take over, that'd be wonderful. Thank you. Whilst we wait for Hergen, and I'll just text them, I wonder whether anyone's got any questions for the Australian speakers so far, whether for Sandra, for Kantan, for Vin, for Aidan, or for Vinod. So I might start by asking Vin. You've been kind of the most experienced person around Australia in terms of centralisation of a service. What's the risk to smaller places not having the ability or the experience to do ECMO versus the potential benefit of moving to larger centres?
Thanks, John. I'll just lower my hand. I was going to ask a question to Quentin, but look, we sort of always thought that that patient and illness factors rather than geography should dictate your access to ECLS. We think that there is an existing wide network of intensive care services spread regionally and to service the and population based in existence, and that a great deal of patient benefit could be derived merely by educating and linking those existing intensive care services to a networked statewide ECMO service. And it doesn't make sense in smaller centres to operate an independent ECMO service, because by the time you've equipped, trained, retained staff, and built a model, you really don't have the patient throughput for to justify that use. And all those cost expenses, whereas identifying the patient, having an easy way to make a referral and get an integrated response between ambulance and ECMO service to your site seemed to us to be the next step in delivering it and making the service available to patients further away. And it's something I think the main thing to say about it is it's something that politicians and governments are very keen to hear, that people have access and you're working to provide improved access. I don't think our statewide service would have been funded without that metric that we present and maintain over time, that we do that. And I think there are a lot of risks to smaller centres trying to run they're an independent service that tries to meet the needs of all the potential patients that could benefit from ECMO. I think it's a really complex specialty, and the other thing about ECMO is it's highly transportable. That there might be others. I'll keep my answer to that because there might be others who want to say more on that.
Lovely. Thanks, Vin. Vin, you had a question for Kantan. Hergen's just setting up, so we might just take the question for Kantan just now, if you would mind.
Yeah, so I'm really interested in the ability to deliver more circulatorily matched VA ECMO rather than continuous flow. But we know that it's quite a large pressure wave that needs to be delivered through a long return cannula and tubing. Just wanted to know more about where we're up to in improving the ability to deliver that. Is it something we can expect in the imminent future, or is it still a long way away?
Thank you, Vin, for your question. I'm not sure to have very good insight in that, because I think to improve the transition of the pulse to human, we have to shorten the cannula to use large, short, and rigid cannula. And that is to balance with clinical needs, because those kind of cannula are not very handy to manage in ICU. And the other part is a lot of the pulse is attenuated by the oxygenator. So what it remains in human is not really known, and I'm not sure to what extent we can expect a pulse in human. Maybe combining, there are other way to, because we are generating pulse, increasing and decreasing the RPM on the ECMO. Maybe combining techniques could improve that. There are techniques that could compress the cannula itself after the oxygenator. And I'm wondering if combining techniques would enhance the pulse that could be transmitted to the human.
Thanks, Kantan.
Thank you.
Hergen's now online. Just a very quick but a very good question from Joseph Rosen. I'll probably direct this to you, Kantan, and you can flick a little bit to Vin. Is there a general flow rate where you've found the sweet spot of not too high and not too low to cause blood trauma? Or is it going to be more patient specific? And Sandra, you're welcome to chime in, but we'll keep it to a 1 minute answer as we've got Hergen roaring and ready to go like a Volkswagen.
In the mock loop, we have a cracked motor. It means it's not the pump that is used by Fresenius. In Fresenius, the RPM are fixed, meaning the difference between the high RPM and the low RPM is set at 3,500 RPM, and we cannot change that. In the mock loop, we are using a larger difference, and when it means we are going from 2 to 6 to 7,000, so meaning a 5,000 difference. But when I asked Fresenius if they had data on one using only 3,500 RPM, and if they have data on hemolysis, they couldn't provide any. So I'm not sure. I think Sandra can have some insight on that, because it would be a great application of using a blood loop to test that, because in the mock loop the amount of blood needed is much too high. So it would mean using a blood loop on that. And I think it would be a great sub-study.
Okay, we might pass there. And Joseph Rosen, if you fancy doing a PhD, get in touch. As we come into the pit lane of Australia, we're going to pass over to Hergen Buscher. And Hergen is going to talk about the anticoagulation for ECMO, questioning current standards based on the work that he's leading very nicely. Thanks, Kantan. And over to you, Hergen.
Thanks, John, and I hope you can hear me, and thanks to giving me the Volkswagen status. Sorry that I was a bit delayed. I had a different start time and had a few clinical things to sort out. Without any further delays, though, I'm just trying to share my screen, and I hope you can see that presentation now.
Yes, we can. Yeah.
Wonderful. Okay, so this topic of anticoagulation during ECMO and questioning the current standard is something I worked with Johannes Graz, previously at Vienna, now at the Charité in Berlin for a little while. And we had a great session on that on ECMONet in Rome earlier this year. This is just a very brief summary of all the discussions we had around that. Starting off with, of course, noting and or probably not necessarily reminding you that bleeding and thromboembolic complications are a large contributor to mortality in patients on ECMO. That's for VV VA ECMO. Very recently, 2 studies investigating the ELSO registry have basically been published, and both found an adjusted odd ratio for a bleeding as well as thromboembolic complication well above 2, and sometimes approaching even as high as 7, depending on what complications you're looking at. So certainly one of the most difficult areas to manage, and we want to reduce mortality and improve patients' outcome, then certainly something to address on. And one of the important questions there is obviously, how do we anticoagulate, and how can that best be done? This is our current standard, I guess, actually, basically defined in the ELSO guidelines from 22, as well as the ISTH guidelines, which basically comes down to, well, of course, a bit more than just that one line. But the first line treatment is unfractured heparin. That's been our, I guess, industry standard for many years and decades, and we've got some debates on if that should be monitored by APDT or an anti-10A. Alternative anticoagulants are noted, but they certainly are treated as second-line anticoagulants, and for example, in indications like HITS, or you've got heparin resistancy, whatever that exactly is. So with that in mind, we actually had systemic literature review on bleeding complication and thromboembolic complications, and try to find out a bit more about that. And we found 159 studies actually reporting on it. And as you could see here, most of them actually have more than moderate risk of bias. Not surprisingly, often they just have single center reports, and the definitions of bleeding and thromboembolic complications are less than optimal. And if we looked into anticoagulation, just summarizing this table, yes, you can see that, I guess, unfractured heparin is king as if it comes to the number of patients being reported, more than 12,000 patients there. And if it comes to major thrombotic events, more than 6,000 patients were investigated. But if you look into the pooled estimate of either bleeding or major thrombosis, we found that there's almost exact match between, for example, an alternative anticoagulants like bivalirudin as a direct thrombin inhibitor and heparin. So we couldn't really find a signal that unfractured heparin is in any way superior or handles those main complications in that field in any way better. Of course, as I said, actually, and admitted myself, the studies were at a very high risk of biases, mostly observational. So Johannes and his group actually have narrowed that down a bit more, and they actually looked into comparative studies only, where basically they had two groups reported, of course, not necessarily or most often not randomized, but often prospective and certainly in a more controlled way. And they could thereby actually compare thromboembolic complications and bleeding events for various alternative anticoagulants in comparison to unfractured heparin. And if you want to take this, as I said, again, the chance of bias is high, but if anything, DTIs, for example, seem to have a signal towards an improved outcome here. And other methods certainly are matching what unfractured heparin is giving us at the moment. So can certainly, I guess, take that as evidence that other methods may be as successful or even better. But again, of course, what we really need is prospective and randomized controlled trials. Fortunately, this is happening, and I'll just summarize a few of these. There is, for example, the casual ECMO study coming out of Vienna, which is 3-arm randomized controlled trial, currently recruiting 90 patients in a single center, and they randomize argatropan as a DTI or low molecular weight heparin against the control of unfractured heparin, and they do look at thrombosis as well as bleeding risks. I think they are halfway through, and we hopefully see some results coming out of this one soon. There is also the local trial here in Sydney, Australia, at our colleagues at Royal Prince Alfred Hospital, where phase 2 RCT is run or labeled the BLUSH trial, where they basically have as an intervention bivalirudin, again against the control of unfractured heparin, this time around anti-10A guided unfractured heparin, and they have as a phase 2 basically efficacy measured in time in therapeutic range, but their secondary outcomes will be as important as well, as we're looking into thrombosis and bleeding. And we're currently in a phase where this trial is almost finishing recruitment, and we're looking into what strategies we can employ to basically make that a phase 3 trial at this point in time. This study probably most anticipated in the field and has finished recruitment from the Netherlands. The group around Alexander Vla and colleagues basically have randomized more than 300 patients on ECMO over 30 months and all participate in Dutch ECMO centers. And they've again had a three-arm non-inferiority design where they randomized a low-dosed unfractured heparin versus low molecular weight heparin versus a high-dose unfractured heparin, and they had a combined primary outcome of major bleeding, severe thromboembolism, and 6 months mortality, and hopefully will report their results well within the year, and that should probably inform us further. A few studies which actually have published already, again from Vienna. There's a lot happening there. This one, however, is from Nina Buchterle in the medical department over there, where they basically had a two-arm phase 2 randomized controlled trial and randomized 78 patients, agatroban versus unfractured heparin. And again, a complication-free time was measured here. Which was defined as days without clinical relevant bleeding or thromboembolism. And this one has been published a few weeks ago at the Blue Journal. And as you can see, with that small and single center experience, they found certainly a signal of comparable results with agatroban and unfractured heparin. This is single center. It certainly also demonstrates that it is possible to run randomized controlled trials on ECMO patients in that field of anticoagulation. And it's one of the first who could actually publish their results. And as it's shown, there will be a few more actually coming in the next year or two. There's another one from the same working group as well, which is one of my personal favorites, actually, where they added on prostaglandin E1 onto just standard anticoagulation, which mostly was unfractured heparin, but in the placebo performed way on 50 patients on VV ECMO only, and their primary outcome was rate of transfused red cells, which unfortunately turned out that the number of red cells needed in both groups wasn't very high. Their secondary outcome, however, was bleeding and thromboembolic events, and they published that as well in the Blue Journal. And indeed, actually, they would have picked their primary outcome differently, that they would have found a significant difference in favor of the prostaglandin E2 infusion if it comes to thromboembolic events as well as bleeding events. So kind of a Goldilocks we want to achieve with anticoagulation, which of course struggling. So I'm hoping for follow-up studies somewhere actually you could confirm these results. So in summary, however, I think I've shown you that we have, or we should have equipoise using various anticoagulants, and this is what we suggested, Johannes and his group and myself last year in the British Journal of Anesthesia, that in general terms we should see unfractured heparin and DTIs, maybe agatroban or bivalirudin, or low molecular weight heparin even as a potential equivalence. We definitely, however, should make clear that the most important bit in that is that we should have a protocolized anticoagulation pathway. And in this summary table, we just summarize the practice in our 2 or 3 centers and gave that as a suggestion. And of course, the prospective and randomized control trials are most important to confirm advantages, in particular subgroups. And of course, patients may behave completely different if it comes to, for example, modes of ECMO, VA versus VV, patients who've been exposed to surgery or not. But we desperately need more prospective studies on that. With that, I conclude and thank you for your attention.
Jürgen, danke. Wonderful again. That last paper and Jürgen's talk summarizes that all this has been something that Bob, that Gail Anich, that so many of us on this call have been working on. It's a difficult question. And that's why internationalisation and working together as a team is absolutely essential, as the three names on that paper show. Hergen, if I can just get you to stop sharing your screen, please, and we might take a question or two. I also just want to acknowledge, I see Wanda's name online. Wanda, I'm not sure if you're in bed yet. No, maybe not. But as I said at the start of my talk, when we say Bob, we mean Bob and Wanda. It was very much teamwork, the two of you, and we're delighted that you've been able to join us this morning. Questions for Hergen just before we move across the Asia Pacific? Hergen, do you think we're ever going to find an absolute answer? Is this question so complex? And again, with my Asia Pacific hat on, Simon Sin and Pong Ng from Hong Kong have highlighted the fact that coagulation in those from an Asian, Sino-Asian background is slightly different from that from Caucasians. We know that pharmacogenetics is a big player. We saw that in the States when aspirin was validated for infarct, but very few Black people were included, and it turns out it doesn't work as well with Black people. Should we in Asia Pacific be looking at it, because this is a way bigger area than the States, he says politically, with 4.3 billion people. Do you think we're going to have region-specific anticoagulation guidelines?
Could have region-specific, and of course, we in Australia and many other countries, of course, have various ethnicities actually. So it should be actually what we are working towards and forward, hopefully, is effectively patient-tailored and individualized treatments. And yes, ethnicity may actually play important roles there as well. And I think, if anything, these few centers actually have proven that randomized controlled trials and running ECMO are possible. And yes, I very much agree and would look forward to have more interventional trials actually run out of our region here as well. And I think it can be done. It just requires collaboration.
Thank you. And Wanda Bartlett, if you want to speak up, of course, you are welcome. I'm not sure how the computers work in that bit, but I'm certain Christine can organise that one. Do we have any other questions for Hergen before we go across the water from Australia to the Philippines? If not, danke, thank you, Hergen, and delighted to now bring in the Philippines that was just recently admitted to the Asia Pacific chapter of ELSO. We had invited our very good friend and researcher, Dr. Chavez, who unfortunately has been in hospital recently himself. But even better, I think we are delighted to welcome Dr. Joan Garcia, who is going to talk to us about a condition I'd never heard of before I arrived in Australia, but is pretty prominent in the Philippines. So this is looking at tropical diseases and ECMO, specifically the use of ECMO with leptospirosis. So Dr. Garcia, if you are online, and hopefully I'm not going too early, I think I'm on time, 8:55. Okay. Okay, we will wait for Dr. Garcia. I see. Sorry, are we there?
Yes, I'm here.
Wonderful.
Good evening, morning.
Hi, Dr. Joan. Thank you very much for joining us. Please pass on our regards to Dr. Chavez when you see him from his international friends online, and we look very much forward to hearing your presentation on a disease so few of us know anything about, and we're delighted that you, Chavez, and the rest of the team there are leading the way. Please, the stage is yours. Thank you.
Thank you, John. Good morning and good evening to everyone joining us from around the world. It is my pleasure to present our Philippine experience with leptospirosis and ECMO. I'm a proud founding member of the Philippine Society of ECMO and an ECMO practitioner at the National Kidney and Transplant Institute, or NKTI, an ELSO member center. So for our objectives, first we'll have a brief review on how leptospirosis affects the lungs, especially the severe complications that can cause respiratory failure. And then we'll also discuss the possible role of ECMO in treating these critically ill patients. And finally, I'll share the outcomes of leptospirosis patients who receive VV ECMO in our center. So leptospirosis remains a major public health problem, especially in developing countries like the Philippines. Heavy rains and flooding increase cases due to contaminated water. And because of this high burden, we frequently encounter severe pulmonary leptospirosis and have gained experience using ECMO in these patients. This graph shows the reported leptospirosis cases in the Philippines provided by the Department of Health from 2011 to 2021. So as you can see, the number of cases fluctuates from year to year. And in 2018, the country experienced another surge in leptospirosis cases after the typhoon Ketsana. And it was around this time that our ECMO journey in managing severe leptospirosis began. Leptospirosis has emerged as an important cause of pulmonary hemorrhage syndrome and acute kidney injury due to Weil's disease. So within the lungs, infection leads to capillary damage driven by VMPX toxins, resulting in blood leakage into the alveolar spaces and subsequent pulmonary hemorrhage. In severe leptospirosis, intraalveolar hemorrhage or pulmonary hemorrhagic syndrome occurs in about 5 to 15% of cases. So severe pulmonary involvement occurs in 17 to 50%, and when it progresses to ARDS, mortality reaches 30 to 60%. Several reports describe the use of ECMO in severe leptospirosis, including ours. Most patients were male and received VV ECMO for respiratory failure, although while only a few required VA ECMO. Overall, most studies reported favorable survival outcomes. This finding suggests that ECMO may be a life-saving therapy in selected patients with severe leptospirosis, particularly those with pulmonary hemorrhage and refractory hypoxemia. In 2018, under the leadership of Dr. Joselito Chavez, we performed our first ECMO for a 47-year-old man with massive pulmonary hemorrhage from leptospirosis. So this milestone demonstrated the feasibility of ECMO and laid the foundation of our ECMO program. This slide summarizes our center's management strategy for leptospirosis-associated pulmonary hemorrhage. So given the suspected immune-mediated component of pulmonary hemorrhage, methylprednisolone pulse therapy and cyclophosphamide were administered. All our patients presented with acute kidney injury requiring hemodialysis prior ECMO initiation, and as part of our management for sepsis, hemoperfusion was done in all our patients. In about 90% of cases, VV ECMO was performed using femoral cannulation and the 10% through femoral jugular approach. Our ECMO patients were maintained under deep sedation with rocuronium, midazolam, and fentanyl. And anticoagulation was maintained with heparin, targeting a PTT of 40 to 60 seconds. Most of our patients were male with a mean age of 30 years. 2/3 were blue-collar workers, reflecting the occupational exposure to contaminated water. Most came from urban areas in Metro Manila, where flooding and poor sanitation increased the risk of infection. So these findings highlight that severe leptospirosis mainly affects young, economically productive individuals. Most patients presented with severe respiratory failure characterized by uncompensated respiratory acidosis and significant hypoxemia. So the mean pH was 7.2, PCO2 of 51, and mean PO2 of 79. Severity scores also reflected critical illness with a mean Apache-2 score of 19 and a mean SOFA score of 15, indicating significant multi-organ dysfunction. The following baseline laboratory findings reflect multi-organ involvement and severe systemic illness. So in our series, the main indication for VV ECMO was refractory hypoxemia despite maximal support. A few, around 10%, presented with refractory respiratory acidosis. Our patients had severe lung injury with a mean Murray score of 3.3, and all presented with pulmonary hemorrhage and bilateral consolidation on chest radiograph. The most common complication was nosocomial pneumonia, occurring in about 60% of our patients, followed by catheter-related bloodstream infection in about 10 to 15%. In terms of mortality, the leading cause was septic shock, accounting for 63% of deaths. Other causes include intractable metabolic acidosis, intracranial hemorrhage, DIC, and air in the ECMO circuit. In terms of outcomes, the shortest duration of ECMO among our leptospirosis survivors was 6 days, while the longest ECMO run for leptospirosis reached 37 days. Encouragingly, the overall survival rate in our cohort was 76%. The next slide shows some of our ECMO survivors, patients who were once at the brink of death but who recovered and returned to their lives because of ECMO. Our first ECMO survivor was actually lost to follow-up, and when our social worker visited him, we found out why. He had already gone back to work and was busy managing several small businesses, including a car wash and a plant shop. This is the patient a few months after ECMO support, fully recovered and even dancing during our Christmas party. We make it a tradition to take a photo with our patients prior to discharge to celebrate their recovery. The survivors remind us that behind every ECMO run is a life given another chance. This was our longest ECMO run for leptospirosis at 37 days. Actually, by the second week, we were already losing hope, and the patient even celebrated his birthday in the ICU while on ECMO. And thankfully, he eventually recovered and was discharged well. Another story that we are truly proud of, this patient returned to the hospital a few months after, but not as a patient. He is now working as a nursing attendant in our operating room. He even assists during our ECMO cannulations. So to date, since June 2018, our center at the National Kidney and Transplant Institute has performed a total of 75 ECMO runs. Of this, 74 were VV ECMO and 1 was eCPR, with an overall survival rate of 65%. Notably, the majority of our VV ECMO cases, about 88%, were due to leptospirosis, reflecting the high burden of the disease in our setting. Among these 66 leptospirosis patients, we achieved a survival rate of 76%. To our knowledge, based on our unpublished institutional experience, the Philippines has the largest number of leptospirosis patients with pulmonary hemorrhage requiring VV ECMO worldwide. I cannot overemphasize that the success of every ECMO run depends on a strong multidisciplinary team working together. So I would like to acknowledge our ECMO team whose dedication and collaboration make every ECMO run possible. From the experience that we gained, we were able to publish our ECMO handbook. This is mainly grounded on the general guidelines provided by ELSO and anchored to our institutional protocol. So this will be my last slide. Thank you for your attention.
Thank you so much for a wonderful presentation of a disease that so many of us really don't know very much about Joanne. We've got time for one question. If people across the world know anything about leptospirosis. As I say, I saw my first case in Australia where a lot of the farmers get at the rats in the fields, and I'd never seen ECMO being used. And I remember receiving a copy of that book from Chavez. So a wonderful piece of work and a new disease pattern. Any questions for Joanne? Okay, Joanne, maybe stay online if you've got some time. We're going to move across to some other presentations. I think we're now going to go to Ramanathan. And just since Wanda is online, I found this fantastic picture of us together. This is with Wanda wearing the jacket. This was down in Florida with the gators in the background there. So Wanda would always steal the show when she came along to the meetings, and it was wonderful to be with her there. So we're going to finish that from the CCRG side of things, and as I say, move on to Ram Ramanathan, who's going to speak to us, I think, from Singapore next. Is that correct, Ram?
Yes, John.
Thank you for joining us, Ram. The computer is all yours.
Thank you. Good morning, good evening to people from all over the world. Really a great initiative talking about Dr. Bartlett's legacy. In fact, my talk is essentially an extension of what Dr. Garcia just presented on leptospirosis. I'm going to focus more on ECMO for tropical diseases. And essentially, this great man had clearly predicted that whatever we do and how many of our patients we save, it all is because of the research we do. And clearly, 50 years back, when Esperanza was on ECMO, little did we imagine that this whole technology would expand to indications beyond our imagination. Clearly, tropical diseases is one of them, and I'll take you through some of the interesting aspects of how tropical diseases can be difficult to treat, and how ECMO can be life-saving in such situations. So clearly, WHO has identified neglected tropical diseases as a major concern in the tropical area. And in fact, there are targets at reducing the burden of disease by 2030. And if you look at it more closely, a set of infections, which are protozoal, viral, bacterial, or fungal, has been identified exclusively by WHO. And if you think tropical diseases is all about infections, no, there are non-infective diseases that are neglected as well. So things such as snake bite poisoning and envenomation. In fact, envenomation by scorpions and wasp bites are increasingly found in the tropical population as compared to the rest of the world, though they are not included in the WHO list. So, and a lot of these patients develop heart failure or respiratory failure as part of their disease process, especially in the severest form. In fact, they present mostly as multi-organ failure, and that's what makes it more difficult to treat. And it's in this context that the use of ECMO has been slowly increasing, whereby as Dr. Garcia mentioned, diseases such as leptospirosis can be managed on ECMO. In addition, there are other tropical infections and non-infections that can be treated on ECMO as well. So let's take a deeper dive into this. One of the important challenges of using ECMO in this particular group is mainly pertains to the logistics. Clearly, there's a lot of patients who cannot afford this. This mainly happens in the outbacks or in the rural areas. So clearly, accessibility is an issue. And then there is a general lack of awareness in and around these areas about ECMO, which is now slowly, catching up essentially, patient education, not just patient education, physician education, as well as awareness about ECMO is slowly increasing. And that's why we're getting to see more patients with tropical diseases getting treated on ECMO. There are medical issues as well with most of these kind of patients. If you look into some of these infections, they invariably cause coagulopathy and thrombocytopenia. And as I said, multi-organ involvement is always a difficult entity to treat, and decision-making on initiation of ECMO becomes tricky. Now, beyond this, clearly, we identified that there have been enough infections where ECMO has been successfully used. I have to confess here that most of these are case reports or case series, so these are all anecdotal, but then that's how evidence accumulates. So over a period of time, you would find that centers such as Dr. Garcia's would do up to 100 cases of patients, 100 cases of ECMO in patients with leptospirosis, and you would slowly accumulate evidence. So there are tropical viral diseases where ECMO evidence has been published, the most common being dengue and MERS. The data on MERS mainly comes from our colleagues in Middle East. Essentially, camel being a carrier of this virus, the Middle East respiratory virus syndrome, can be quite difficult to treat, and in severe form of respiratory failure, patients would need ECMO. Clearly, our colleagues, when they had the outbreak, they published this data and showed that ECMO can be used successfully in select patients. The same thing applies to patients with fulminant dengue myocarditis, which is essentially spread by Aedes mosquito. It's a human to mosquito to human transmission, and essentially the mosquito gets infected before it infects the humans. And the use, and there is an entity called as dengue shock syndrome, and sometimes you get to see patients with dengue getting dengue myocarditis as well, where ECMO has been successfully used. The graph essentially reflects data from my colleagues in India, where they have used ECMO in dengue and viral hemorrhagic fevers. So clearly, if you go by some of the available data, and I should thank my colleagues again for sharing this slide. Essentially, not just malaria or dengue, even in viral hemorrhagic fevers and scrub typhus, ECMO has been helpful. While the numbers might be pretty small here, what is striking here is essentially that a lot of these diseases, the survival rates are quite acceptable or really, on par with the rest of survival with other diseases. Of course, the list of tropical bacterial disease where ECMO has been used is definitely high. We heard about leptospirosis. Milioidosis is something unique to this region, caused by Burkholderia, and you would find that some of these patients have a genetic susceptibility to get not treated with regular antibiotics. And this was one of our patients who stayed long on VV ECMO just because she had an aberration of her interferon pathway, which we eventually diagnosed with genetic tests. And in fact, at that point, she had already received quite a lot of antibiotics and she was not responding at all. All she needed was treatment with interferon gamma, and the whole picture changed overnight. And that antibiotics would then work. So clearly, going on to say a lot of work is being done in this area, and clearly, we are also identifying that such infections are not just limited by its pathogenesis, but also by its by our ability to treat them, and the host response can sometimes be different, and you might have to take a different approach when you treat them on ECMO. I think there is a talk coming up on the use of ECMO in tuberculosis. So I don't want to spill the bean, but clearly, this is another disease of the tropics where survival is up to 50 to 55%. You do have fungal diseases where ECMO has been used. Parasitic infections are quite common in the tropics, especially things like Chagas disease in South America, where myocarditis is quite common, or heart failure is quite common. Similarly, hydatid disease, and most commonly in the Asian tropical region, malaria is very common. So in Africa as well. And these diseases can present again as with severe ARDS or with severe heart failure requiring VA ECMO. And all these diseases are treatable diseases, reversible diseases, and ECMO just provides a bridge to support these patients' organs till the anti-helminths or the antibiotics kick in. Last but not the least, clearly, as I said, unique tropical disease that you would find would be the snake bites, where ECMO has been used. Scorpion bites can cause severe autonomic dysfunction leading to heart failure or even ARDS in some instances. And clearly, ECMO has been used in such instances too. vast bites, essentially, it has a neuromuscular blocking agent, the active disease-causing chemical, and it can present with respiratory failure and ARDS. Clearly, I'm highlighting only the case reports, but just going on to say the spectrum of diseases, the tropical diseases that get treated with ECMO in the tropics, you may find that these indications are unique to this area. So from a tropical diseases perspective, clearly, I feel we do have infections where ECMO can be helpful. And of course, we have envenomation from insects and other things. Like things like snakes, scorpion bites, and spiders. Clearly, tropics is a creepy area sometimes, and you might need ECMO as a rescue therapy. So clearly, as I said, this is a very great initiative, and I'm sure the legacy continues with us clearly using ECMO in different contexts, and in the tropics. That's what I have presented so far. Thank you.
Ram, thanks so much, and it's wonderful to hear all the different things that perhaps we in Asia Pacific get that the rest of the world doesn't get. I always point out that the 20 most poisonous animals in the world, 17 of them are in Australia. But thankfully we don't have guns down here, so that saves a whole pile of lives, but let's not go there. Ram, we might have some questions for Ram before we go on to Dr. Chen, which will be a fantastic talk, I'm sure, from Taiwan. Any questions for Ram about, or Dr. Garcia, about the tropical diseases and envenomations? Ram, I might just ask one question as well, so check if Chen's online. Does Singapore, I mean, it's obviously a concrete jungle out there, but you've got a whole pile of greenery. Do you get many envenomations in Singapore? Has it been brought in from the outlying areas?
Yeah, we do have snakes and other things around, scorpions around, and we don't get them to the point where they go into, severe cardiopulmonary failure and then go on ECMO. So clearly, we do get envenomations once in a while, but not to the point of needing ECMO. Yeah.
Okay, good. Thank you. We see a number of them here. Not many of them need ECMO, but occasionally they do for the, as you say, the myocarditis. Well, Ram, thank you very much from Singapore. We're going to move across the water to Taiwan and lovely Taipei, where Yishar Chen, who was the second president of Asia Pacific ELSO, is going to talk to us about the inspiration from Michigan to Taiwan and the evolution of mechanical circulatory support. So, xie, Dr. Chen, and the screen is yours.
Thank you. Do you see my slide? Or not so
Yeah, if
good?
you just go into slideshow, yeah.
Slideshow, wait a moment. Yeah, but I'm not sure.
Yeah, it should come now.
Yeah, it's coming. But just slowly. It's okay now?
Yep, that's lovely.
Okay. Some problem over there. Okay, and let me see. I am. Yes. Okay. Okay. Thank you, Ho Jiong. Thank you. We have the opportunity to inspire from the U of M. I think I have training in Michigan for 1996 to 1997, and actually in Taiwan, our first cases ECMO is since 1994. Interesting. The first case I don't know what list to go for, and when I'm training in Michigan, I visited Bartlett once. Then I go back to Michigan in 1990 for the ELSO meeting. In that time, I learned what is the ECPR. Actually, at the beginning, I don't know what we are doing in the early of the 1994. Then after that, he Bob go to our hospital in 2001, and I visited him in several times in 2005 and 2015. Okay, sorry. And our cases it start from 1994. Then we rising start to accumulate the case of the ECMO because I'm working on the CVS doctor, and we have some problem at the beginning for the cardiovascular surgery. So we have a lot of operation. So we reached the 2000 about 20 years later. Then 3,000 in 2020, 4,000 in 2024. Then nowadays we approach to 5,000. This is our general result in my hospital, and as well as in Taiwan. The result is we have a lot of run because of the reimbursed by the all commercial reimbursement system. So the Taiwan population not so many, but the ECMO run in Taiwan accounted for 50% of the ELSA data. This is our general group of the study. Then we actually we start our eCPR program very early, and we published the first data in JACC 2003. We found, and also in CCM in 2008. Then we found the result of selection criteria, selection patient encouraged the eCPR in application. And so we published the data in Lancet, and also we know we can extend the eCPR duration up to 90 minutes. So we also curious about the INCA and OCA, and found the interesting things in our hospital. The OCA results are similar to the INCA result. It may be related to the emergency doctor help us to selection a proper the suitable patient to implant the ECMO. So our result was quite similar between the OCA as well as the INCA. So we also published the data a lot of related to this problem. We know the survival threshold around the 75 minutes. So we know when the patient with the more than 75 minutes, the dramatic decay in the survival. So we must put on the ECMO as soon as possible, less than 75 minutes. So we also found there are some patients with the elder patient can survive. Some elders cannot. Is there something a difference between the resuscitation time? So we also published data in intensive care medicine about 5 years ago. We know that the younger patient may tolerate longer low flow, and once the patient older than 75 years old, then he resuscitation later, less than 30, longer than 30 to 40 minutes, he cannot have the good result. That's we show here. Let me see here. Okay. We show this white bar, yellow bar here. Oh, okay. Oh, okay. Then from our 15 years observation study, we found that the oxygenation affect immunologic outcome at the beginning received the eCPR. So we suggest do not have the high FiO2 at the beginning after the initiation ECMO in the resuscitated patient. So is there body service make a difference? Yes, it is. If the patient with the BMI is too low and also the BMI is too high, the result is not so good in the patient with the eCPR. So if we want to have the good result, we should choose the better BMI patient. And how about the end-stage heart failure? End-stage renal failure. We know there are some contraindication for the patient with the end-stage end-stage renal failure. But from our data shows there are no difference between the two groups. Once the patient, whether he or she did not have the renal failure, he still have the right to receive resuscitation, to put on ECMO. Then how about this is our study about the endotoxin activity study. We are doing we found that if the high EA endotoxin activity is high, the results is not so good. So we can check the endotoxin at the beginning of the ECMO. We can choose which one is better result, which one is not better result. Okay. Oh my God. Okay, sorry. So this also the data shows once the elevation of the endotoxin activity, the result is significant at the 2 days to 3 days. And so we are also curious about the decision making, the process of the decision making when we put on the ECMO. Usually the safe score talk about as the result at the beginning of the ECMO. So we are curious about when we do a put on ECMO, should we do something, do some process, so some procedure will improve the result. So we developed the Rescue 24 score. It means there's several scores. You can see here, once that after 24 hours, if the result is not improved, especially the lactate clearance is not so improved, and still they have the oliguria, and the result may be not good. So the AUC curve about the Rescue 24, the AUC about 0.9. So it's much better than the so far than the Apache than the SEMA score. So you can superior differentiate the early mortality. So this is our result. If it is high, it means it may be survival is not so good, or we should do something else. And by the way, when we check the Rescue 24 hour at the 24 hour at the time of the 24 hour, if the patient data not improve, we should change our policy. So this is the first day decision support we can have. So from this the thinking process, we start to think, if we do the patient with the ECMO, should we do the unloading strategy in the viewpoint of the organ vulnerability reserve, such as we have do the SABRE score with organ vulnerability head round. Heat map shows the result here, and also we show the Rescue 25 and 34 and plus organ vulnerability heat map. So you can see the result is quite different, quite poor in the group of the organ non-vulnerability. So we have some study now. We start to think maybe timing of the unloading may be related to at the beginning. We can have this is our organ vulnerability score with the bilirubin with the urine, and if the 2 point is good, it means the vulnerability, and you can check the ECMO at the beginning. Is the organ is not good. The result is good. Is poor. We should put on the LV bed, and if it is going on, it's good. So it may our procedure is quite acceptable, and the clinical may be improved. So this is the data maybe show in the AP also this year. So in Taiwan, we also start our program about the ECLS in all cases. The study already begin in 2024, and we now include about 100 cases. Our plan is include 400 cases in this study. We will publish your data later. One more thing, innovation is what is the innovation? We have, everybody know, hypothermia may have another systemic effect, and the emergency doctor always believe hypothermia may improve the brain, but in the ECMO it's really good. So, but too cool may be damage the body. But even when the temperature less than 33, so how about if you put the two temperature between brain low and the body warm? So we developed the cerebral selective deep hypothermia with 2 pumps. It's quite complicated. So we only performed in 4 cases in 2015 in HA. And the result is quite amazing. But because of the setting is so complicated, we try to revise our design later to from the 2 loop to the 1.5 loop later. So this is the data we have got. And we have recently breakthrough. As everybody know, I'm the cardiac surgeon, so we do something crazy idea and the crazy procedure. One is the 0 ischemia time heart transplantation. The other is the robotic heart transplantation. Maybe the first 2 or 3 cases in the world. And we have do some vet for LV rupture, and so we also do the Harmony 6. This is the first case we published in the JDC. There we continue perfuse from the one heart to the other room of recipient, so we can do the 0 ischemia time in beating heart without stopping beating, without using the cardiac pressure. And we have do 2 cases. Now this one is the robotic heart transplantation. This is a patient under the heart transplantation. We extract the heart, remove the heart, then this is remove the heart, take the heart out. The most difficult procedure in this robotic heart transplantation is to take out the heart, because the heart is too big, so you will destroy the heart. Then we put on the new heart in. The heart is quite small, so it's easy to make a stitch, to make a suture. So we have now we have done 1 cases, especially maybe the first cases in the world we do this procedure from the right thoracotomy, not in the previous. They have the procedure from the low sternotomy. Okay. Cool. Oh, okay, sorry. My God. Okay. We also have the chance to do the total artificial heart. In 1 cases, this the patient with a arrhythmic VT quite a long time and with the CAD. So we take out the whole ventricle and put 2 Harmony 6. In Taiwan, we don't have a bivalve cord, so we cannot do the bivalve cord. So we just replace by the Harmony 6. This is the procedure we have done. And we also do the LA drainage. This case may be the longest survival in the world. Have the LA drainage by the Harmony 3. This case delayed the heart transplant because the patient has the multiple myeloma and treated. Maybe next year, maybe 5 years, so he may have a chance to get a heart transplantation. Okay, don't forget ECMO. There's no I in it, so it means there's teamwork. So we 6 Bob have some endorse for our hospital. This is the mayor of the Taipei city, and also I get the advantage to advise. I have hosted the this year 2026 the Asia Pacific meeting artificial organ in Taiwan. Welcome to Taipei. Thank you.
谢谢 Dr. Chen. As always, a fascinating talk. Wonderful to see the robotic heart transplant there. And we're going to move very shortly over to Hong Kong. I'm not sure what time we transition across. If someone could just give me a text in the chat room. If you can just stop sharing your screen for 1 second, that'd be wonderful, Chen. Thank you. Look, in terms of the BIVAD, I'm not sure whether David McGiffin's online here, but we've done a number of BIVADs, LVAD and RVAD. Works beautifully, but as you say, total artificial hearts, like Bivacor, have got a huge potential. But again, it's onwards and upwards, and I know that Bob and Daniel Timms, the inventor of Bivacor, had many good discussions about what was to come next. Just before we move across to Dr. Tammy Ma in Hong Kong, who's going to talk about a fascinating technique that's now been co-developed between Hong Kong, Brij Patel in London, and a number of other groups. I'll just ask if anyone's got questions for Chen. You can put them in the question and answer bit as well if people are interested. Okay, what we might do, thanks Chen for joining. I know you're busy there in the morning. Stay online if you can for a little bit. And we're going to transition directly to Dr. Tammy Ma, who's from the Policy Research Centre, works alongside Pauline Ng and Simon Zinn, two wonderful people at Hong Kong that we work along with. And as I say, they're starting to really co-develop research right from the floor up in terms of weaning mechanisms, which we know in VA ECMO is massively problematic. So this is a technology that Pauline really came to us with a question. She's done some amazing work, and then Brij, so Pauline and the team's work. And then in the last ECMONet meeting, we really have got an international team together to look at this. So Tammy, the screen is all yours. Thank you. We're all looking forward to your presentation. Thank you. Can't hear you yet, Tammy. Are you there? I can see your slides.
Hello. Can you hear me? Oh, okay.
Yes, got you now. Thank you.
Thank you. Thank you for the introduction. So today I'm going to talk about the PCRTO in ECMO weaning. So the background of this topic is that despite the increasing utilization of the ECMO, actually there is currently no standardized protocol for weaning. Flow reduction to approximately 1 liter and AV bridging recirculation have been the two most common methods employed in ECMO weaning. Approximately a decade ago, an alternative weaning strategy known as the pump control retrograde trial of the PCRTO was developed and has been predominantly described in the pediatric patients. To test the PCRTO as a VA ECMO weaning strategy in adults, we perform a single-center case series in Queen Mary Hospital in Hong Kong. We include all patients who had PCRTO performed as ECMO weaning trial from January 2019 to July 2021. Patients without any myocardial recovery would be excluded as they would not benefit from the ECMO weaning. To start with, we need to ensure the anticoagulation target is about 1.5 to 2 times of the normal APTT that has been achieved. And the setup for this PCRTO involves gradually reducing the flow, similar to the flow reduction method, but to the extent that the patient's SBP remains greater than the pressure generated downstream by the ECMO pump. At that point, blood will flow from the patient through the arterial side of the pump to the ECMO circuit, then to the venous cannula. Since the resistance of the ECMO circuit is much lower than the systemic vascular resistance, blood will preferentially flow through the ECMO. To prevent all blood from shunting, we need to control the ECMO pump to allow only 500 ml to 1 liters of blood through the circuit. So that's why it's called controlled retrograde trial. The reperfusion catheter to our lower limb is connected to the pressure set for monitoring. Then a comprehensive hemodynamics monitoring, including echocardiogram, will be performed during the trial. Because of the shunt, it causes three effects during the trial. First, there is a reduction in SVR as ECMO support is stopped, leading to a decrease in the MAP. This tests the cardiopulmonary reserve's ability to increase the cardiac output in a vasodilated state. This is often important because the patient may experience some surge response after the decannulation, and it can simulate a vasodilatory state and evaluate how well the heart can cope. Second, since ECMO no longer drains blood to the circuit, all blood will return to the RV and LV. This tests the ability of both ventricles to handle the full load. As the entire circulation passes from the RV to the LV through the pulmonary circulation, this can test the RV's capacity to handle the afterload and how the pulmonary vascular system adapts to the increased flow. Using PCRTO offers the advantages such as the physiological effect, which was explained, and a reduced risk of clot formation due to the increased blood flow within the circuit when compared to the AV bridging recirculation. However, it also has some disadvantages, including a theoretical risk of thromboembolic events. This risk arises because reversing flow might push the clots formed in the circuit during the PCRTO into the systemic circulation, and a risk of ischemic limbs issue related to the arterial side cannula. In the Asian population, our CFA is smaller than the Caucasians. Even with a 15 French return cannula for ECMO, there are cases where the cannula completely occludes the blood flow to the SFA, making the lower limb depend on a reperfusion catheter. This is especially true after days of ECMO when clots form in the shaded area during the as shown. And during PCRTO, the reperfusion catheter connects to saline, cutting off the circulation to the limb and risking ischemia. So patients often feel numbness and show a drop in NIRS reading, but this usually resolves once ECMO support resumes. So with this background, let's have a look on the study we had. The primary outcome for this study is the successful weaning by using the PCRTO from the VA ECMO support. And the secondary outcome is the successful completion of the planned duration of PCRTO. Other potential causes of failed PCRTO, including those we mentioned before, like those cardiac decompensation, impaired lower limb perfusion adequacy, and embolic events were also documented. So 86 patients throughout these 3 years were received VA ECMO in our center. 36 patients were included and received total 57 runs of PCRTO. 50 patients were excluded because of absence of myocardial recovery. They were either bridged to further therapies such as the LVAD, central VA ECMO, or heart transplant, or had active withdrawal because of the underlying guarded prognosis. The median age was 57 years old, and most of the patients were male. The major indications for the VA ECMO are the myocardial infarction and myocarditis. And for the PCRTO trial, the median retrograde flow rate was around 0.6 liter per minute, and the median duration of PCRTO for our center was 180 minutes. The left-hand side presents the KM curve for the time to ECMO decannulation. Among the 35 patients who experienced at least one successful PCRTO, 31 patients, around near 90%, were ultimately weaned from ECMO successfully. There are few patients left. The 4 patients who did not undergo decannulation is simply because due to the care withdrawal following the diagnosis of hypoxic brain injury. And there was also 1 patient who was decannulated despite not having any successful attempts of PCRTO, as the patient had limited perfusion of the lower limb during PCRTO while the patient was actually hemodynamically robust and deemed fit for ECMO decannulation. The right-hand sided KM curve demonstrates the time to death in the cohort. The 30-day to 90-day survival among those who are successful PCRTO was near 70%. So regarding the secondary outcome, 45 out of 57 PCLTO sections were successfully completed. The reasons for unsuccessful PCLTO procedures, which necessitate the restoration of VA ECMO, included the worsened RV failure, transient hypoperfusion of the lower limb on the ECMO return side, as detected by the NIRS, seizure episodes, and coincidental acute obstruction of the ETT. The patient's condition returned to baseline after cessation of the PCLTO and no significant complications in the ECMO circuit attributed to the procedure, and there are also no significant complications in patients. So additionally, there are no cases in our cohort required circuit replacement after the PCLTO. So according to our study, PCLTO is a feasible strategy for evaluating readiness for weaning from VA ECMO, characterized by a low risk of adverse event and a high predictive accuracy for subsequent successful ECMO decannulation. However, this study also still possesses some limitations. Firstly, due to the utilization of the PCLTO as the default weaning approach in our department, a matched control group was not incorporated. Secondly, being a single center study, the applicability of the PCLTO to other ECMO configurations and care settings remain to be validated. And RV function was not systematically evaluated during the PCLTO with PAC or comprehensive echo assessment. So lastly, although no clinical significant embolization was observed, but there's no systemic screening for the thromboembolic event before and after PCLTO, such as some like routine whole body CT was not performed, so which may result in underestimation of the thromboembolic incidence. So because of these limitations in our previous study, so as mentioned by Professor John Fraser. So looking ahead, we are going to have a collaboration with the Australian team, the UK team, or Japan team. So for further study. So looking ahead, our PCLTO research roadmap should focus on some critical areas, such as first, comprehensive hemodynamic and physiological evaluation must be conducted to assess the PCLTO impact on the ECMO weaning in patients with RV failure. Second, we also plan to undertake multi-center studies to evaluate the performance of various PCLTO configuration across diverse clinical settings, thereby ensuring broad applicability. And finally, a more extensive safety assessment would also be carried out for PCLTO to identify any evidence of embolization. So these studies will provide the robust evidence needed to establish PCLTO as a validated weaning option for ECMO. So thank you.
Ami, wonderful presentation, and it's a great example, if you can stop sharing your screen, a great example about how we can learn from ELSO. Many techniques are just started with the hope, the optimism that they may well work. And when Team Hong Kong kicked off, and I think Pauline is online, with this as an idea, and then in London, Brij Patel following, and then a lot of us getting interested to this study led by Hong Kong. The question was, rather than do a 10-year study and actually realize we're studying the wrong thing, how could we develop this from the ground up? And that involves, the clinical case series that you've talked about that's done so well, and Bridges as well. And then there's a study called the Socrates study that, again, Hong Kong, London ourselves, Q8 and other groups are now starting to join in. How can we investigate this from before we go to humans? We know that the Eolia study was a phenomenal piece of work, but the p-value was 0.07. So after 10 years, we had an answer that's probably significant, but maybe so. When we presented, and Pauline presented this in London, we had methodologists, Professor Marion Campbell, who's done a lot of methodological studies in surgical outcomes. And, we talk about treatment A versus treatment B and antibiotics and fluids, but the surgeons tend to just say, this is the way I do it. So this is a technique that is fascinating, that is complex, that is high risk, and that needs exactly the coming together of a global team. And again, we hope through your work, through Hong Kong's work, and everyone else's, we can actually study the right question in the right manner. So thank you for that presentation. You've inspired a fair amount of questions, which is lovely. So from Kenya's leader in ECMO, Dr. Nichifatso Bonyo. Tammy, thanks for the presentation. I'm curious about the right ventricle reported as a secondary outcome. How was it diagnosed? Was it just with echo, or were PV catheters used as well?
Thank you for the questions. So for the RV failure, usually we will first screen by the echo first, because usually we will first do the echo at the 1 liters, and then we do our retrograde flow. So before that, we have the diagnosis in our mind that whether the patient is suffering from predominantly left LV failure, RV failure, or even bivent failure. So for those cases, like from the echo or the underlying the pathology, like the PE or thing, we suspect or some myocarditis with biventricular failure. So we will perform echo and on top on a PAC. So we will, based on the PAC finding and doing our retrograde trial, we will look for like whether there is any change in the mean PA pressure, and how's the is there any evidence like progressive pressure building up in the venous system suggestive of worsening RV failure. So if there is like worsening of the RV failure, we will terminate our support. So it is a diagnosis based on the echo and also the PAC, but we will first screen by the echo. If there is evidence of RV failure or impaired RV function, we will go for a PAC as well.
Great, and nice comprehensive answer. I'm going to move on to the next question by Stephen Derdak. Do you routinely look left to right shunt, PFOs and ASDs, or occult drain cannula with ultrasound prior to doing it? And I guess you've talked about the importance of echo. I think we all do that. If either are found, would you be concerned about doing PCRTO because of the backflow and the risk right to left shunt?
This is a very good question. Thank you again. We didn't have like routine doing the echo to look for the right to left shunt, but doing the ECMO, because usually it's because of the venous drainage. So sometimes it's very difficult when to do a like screening for the PFO unless you are doing a TEE. So we don't have a routine screening for that. But from our results so far, we didn't have any significant like embolic event, but this is a very good suggestions for that.
Thank you. And now there was one more question just coming from Eric Wu, one of our, hold on, I just lost it. Where is it going? Look, whilst I've lost that other question. Oh yes, Stephen Horton's question. Thank you. From the diagram, it looked like you're using a cardio help. If you have retrograde flow for more than 6 seconds, it goes to zero. So a nice pragmatic question. If it goes from 6 seconds, it goes to zero flow and alarms. How did you set it up, and how did you avoid getting told into trouble by the hospital administrators?
Yes, this is also one of our trick because of the cardio help, as mentioned. There is like safety mechanism to guard the retrograde flow. So usually we will slowly when we like first of all we'll set the blood flow to around 1 liters, and then we will gradually titrate down the flow until around 500 mils, and then at that moment we will remove our flow probe, and then we will further titrate down our flow until it started to retrograde. And at that point, we will swap the flow pressure, the flow probe, just to check the cardio help. So because of the reversal of the flow probe, and then actually the cardio help cannot distinguish it is like reverse flow. So that alarm will be resolved.
Okay. So I might ask a question, if I may, Tammy. So how difficult was it? We talk about having a champion, and I think obviously Hong Kong is doing a great job there. Having a champion behind this, how difficult was it for you to get your nursing staff, your allied health behind this as a project? Was it, it takes a huge amount of leadership and foresight to bring in new techniques. I think we're all aware of that. How difficult was it, and what are the kind of things that your unit would, if you did this again from kickoff, what would you do differently about trying to inspire a whole new process that a lot of people could see paradoxical?
I think I'm quite lucky that because our team have a lot of perfusionists, the ECMO nurses, they are very capable, and they are also very enthusiastic in dealing with this. So in our team there are few ECMO specialist nurse, and then they will try to actually we are instead of being doctor very superior, actually we are trying to discuss our thinking, and then how are we going to manage the patient, and then the nurses will also give their advice, and sometimes they will give us a lot of inspiration, especially because they are the one who take care of the patients and the circuit most of the time, especially weaning, and then so they can give us some inspiration, and how we can, for example, the alarm part, actually they did it very well, and also the reperfusion catheter, they are also the one who think about how to flush the reperfusion catheter to prevent the clot formation during the retrograde and minimizing the ischemic limb issue. So I think for a program to be succeed, it really depends on whether there is any good communication and teamwork with the whole team, so that this can develop well.
And again, another brief question in terms of the anticoagulation when you go down. Did you look at different studies about? I mean, obviously we give boluses of heparin when we slow down the pump. Do you use the same anticoagulation profile using PCRTO, or do you change? Have you got a different profile in terms of anticoagulation strategy?
We use the same profile. Just keep around 1.5 to 2 times of the normal value. So if the before our retrograde, if the anticoagulation is below the limit, usually we will give a bolus of heparin, so that it can be we need to ensure that the anticoagulation level to be achieved first to minimize the embolic risk.
And just our last question, we're just going to be joining Brian Lau, also from Hong Kong, so we don't want to make your colleague upset if you're stealing too much of his thunder. In terms of the anticoagulation, are you also looking at blood markers to determine whether that anticoagulation is correct? As you say, you've just adapted it. Have you looked at any blood markers or subhemolytic cell damage to show that you've got the right, or are we just doing it on clinical bases, Tammy?
You should you mean
specific blood markers to determine whether your PCRTO is different. You've accepted another the older strategy of anticoagulation as we go into PCRTO. Are you doing any in-depth analysis of blood coagulation markers as you're doing it, or are you just looking clinically?
This is a very good suggestion. We are just looking clinically right now. We haven't doing any blood markers for that yet.
Okay, I think it'd be an interesting area, and perhaps with Pauline and Eric, we're head engineers, that might be worth looking at. So right on time, again, we are Asia Pacific, so we love to be on time and perfectly organised. We'll say thank you to Tammy and introduce another of our great colleagues from Hong Kong, Dr. Brian Lau, who's going to talk about bridging theory and practice and managing the impeller through simulation-based training. And we'll invite Brian to take over the computer. As he does, I think it's important to realise how strong the education side of things is coming from Hong Kong. Simon and the team have done an amazing job. And in fact, during the pandemic, when Indonesia wanted to open its own ECMO program, Simon and the team, a load of us helped, but realistically, it was Hong Kong that taught Indonesia how to create a whole ECMO system and did it very successfully. So saying Shise and goodbye to Tammy, and then we'll pass on to Brian, whom I hope is online as it's now 9:58 on the dot. Brian, are you there?
Yeah, thank you for the very kind introduction, Dr. Fraser. So I'll share my screen.
Please do.
Yes. Yes. Is the screen okay?
It's perfect, yep.
Yep. So good morning, everyone. My name is Brian, also from Queen Mary Hospital in Hong Kong. And today I'm sharing our work on breaching theory and practice in managing impeller through simulation-based training. So although this project focuses on impeller, it actually stemmed from our ECMO training experience and shows how we adapted those lessons to build an impeller simulation program. Yes. So let me begin by explaining why this is so important right now. So we are actually all seeing the same trend. The use of mechanical circulatory support is expanding very rapidly, as well as its complexity and duration. And the indications of impeller are actually moving beyond high-risk PCI into prolonged ICU support and also LV unloading in patients on ECMO. So the longer patients stay on these devices, the more opportunities we have to encounter critical events. And secondly, these patients are extremely fragile, often requiring both ECMO and impeller with narrow margins for errors. And thirdly, I think it's the most important point because we have quite a low patient volumes combined with high complexity. And this combination creates the perfect storm for device-related adverse events. So what's the problem with traditional training? So look at the left column. It's the typical approach using web-based learning modules, didactic lectures, and bedside experience. I would say these are all valuable to gain knowledge relevant to the device. But look at the gaps on the right. Cognitive knowledge does not always translate into psychomotor performance. Well, you can still pass the multiple choice test and still freeze when an impeller alarm strikes you in the midnight. And also, given the low case volume, we may have limited hands-on practice, no margin for errors for these very critically ill patients, and also variable confidence levels among staff. And sometimes life-threatening events or rapid decision-making under pressure cannot be developed through passive learning as well. And these are exactly what we face with ECMO training too. The gap between knowing what to do and actually doing it competently. And that's what we are trying to close. So we designed a mixed method study, a one-group pre-post testing combined with qualitative focus group interviews. We recruited critical care nurses from various ICUs at Queen Mary in Hong Kong and measured key 3 outcomes, namely knowledge, self-efficacy, and real-world application through qualitative interviews. This mixed methods approach was crucial, I think, because we didn't just want to see the quantitative test score. We wanted to understand how training actually changed behavior in practice. So our intervention was a 3-hour simulation training section. The first 30 minutes of interactive teaching will include a systematic circuit checks, then 120 minutes on 4 high-fidelity simulation scenarios with structured debriefing after each one. And finally, to wrap up, we will have a 30-minute of hands-on skills practice, things like changing the automated impeller controller and purge cassette. And another important point is we kept groups small, around 6 to 8 participants per section to allow everyone to actively participate and learn from each other. The 4 scenarios we designed covered suction alarm, catheter malposition, resuscitation, and global perfusion inadequacy. So we identified these scenarios through like incident reviews, post-event debriefings, and annual training needs analyses. And these problems were actually really the problems that our nurses were facing at the bedside. So this is what our training looked like in action, from interactive didactic sections reviewing impeller circuit and alarm management to full high fidelity scenario simulation at the bedside. So now let's look at the results. Knowledge scores improved from 11 to 14 out of 15 immediately post-training, and it was sustained at 3 months as well, while the self-efficacy self-efficacy scores jumped from 21 to 30 out of 40, which is around a 43% increase in confidence, and satisfaction was consistently high at 22.5 out of 25. But let me show you what numbers can't fully capture in our work. So just listen to what our nurses said. The simulation training allows me to visualize scenarios before encountering real patients and thereby improving my preparedness. So I think this is much like a mental rehearsal and is proven to improve their performance. And other nurse recounted that without any hesitation, we directly defibrillate the patient as this was addressed during the simulation. And well, this is exactly what we want, like confident and immediate actions in the crisis because they have practiced it before in a controlled environment in our simulation program. And without debriefing, you will not know if you did things correctly. So they recognize that reflection is very essential for learning. And the last point is that the simulation reinforces everyone's approach. I think this is quite important because it speaks about standardization. So the participants all acquire the same systematic approach to circuit checks and troubleshooting, which improves team coordination as well as how they are going to manage crisis in a very chaotic situation in a systematic approach. So I think these quotes reveal something crucial. Training changed not just knowledge, but confidence, decision-making, as well as team alignment. So what made this training successful? I think simulation's effectiveness relies on 4 core pedagogical mechanisms. So firstly, it's about psychological safety through what we call a fiction contract. It was foundational because everyone has to agree that the simulation area is a safe place where mistakes are expected and valuable. And participants will then feel safe to take risks or make mistakes and learn through them. And secondly, it's a structured debriefing because the scenario itself is just an experience. Debriefing has the ability to transform experience into actionable knowledge. So we use a structured approach to help participants reflect on what happened, why it happened, and what they would do differently next time. And thirdly, small group format also optimize engagement. Everyone had a voice and everyone can participate in the simulation. I think the hot seat design is also very important because 2 participants actively manage each scenario while the remaining participants will observe. This maximizes learning efficiency. Everyone learns from watching and discussing, not just from doing. So our mixed methods approach revealed some contextual factors that quantitative test scores alone would have missed, like how training actually changed real-world decision-making and improved team dynamics. So a few practical considerations for implementation. Firstly, is about timing. Studies reported that skills decay within 6 to 18 months. So we still don't know when the acquired skills start to decay in reality, but we still recommend regular refreshers like annual or biannually. Secondly, for resources, simulation training is really inherently resource intensive, like we have to use high fidelity equipment. We have a pool of trained facilitators. We also have to make sure the staff is trained under protected time. But I think simulation training is still very essential in part of our training. I think our view is that this training should occur like during staff paid work hours, not as an add-on to personal time, and perhaps exploring training in a more condensed format to maintain sustainability is something we'll need to consider going forward. And here's our biggest challenge, linking training to patient outcomes. So this brings us to the Kirkpatrick model is used to evaluate effectiveness of training programs. We have demonstrated the first 3 levels, like satisfaction, knowledge gains, and behavioral change in practice. But level 4 is very difficult on how we are going to prove the impact on patient outcomes because the complexity of critically ill patients and numerous clinical confounders makes it very challenging to isolate the training effects. But I hope this is something we will tackle next in the very near future. So last but not least is about what does this mean for ECMO training. I think firstly, the knowledge practice gap is real, and web-based modules or didactic lectures are actually not sufficient for low volume, high risk devices. Whether it's Impeller or ECMO, passive learning does not seem to suffice. And secondly, simulation works, but we still have to look beyond Kirkpatrick level 1 and 2. We achieved level 3 behavioral change, but showing a clear impact on patient outcomes at level 4 is still an unresolved challenge. And thirdly, it's about this training is not just an impeller training. I think this is an entire MCS training story, because ECMO also faces the identical challenges: low volume, high complexity, devastating consequences when error occurs. So the way we design simulation, conduct debriefing, and track behavioral changes, also, I think it's transferable to ECMO program as well. So what is the way forward? The question is how we prove training can improve outcomes in very complex populations. So instead, we may need to focus on what we can measure, like competency maintenance, error reduction, and time to intervention during some chaotic situation. I think these are meaningful proxies for patient safety. We may never show a direct causal linkage to mortality reduction, but I think we can still demonstrate that trained teams respond faster, make fewer errors, and sustain their skills over time. So, yes, thank you very much.
Ryan, thank you very much for an incredible presentation. And as you say, all the science in the world is not relevant unless we have good education. That's the implementation. And it's wonderful to see the way that you're scientifically and rigorously going through that mechanism. So thank you very much. Life does get in the way of education. I'm delighted to have hosted the first part. The nursing staff are going to shoot me because I still haven't done my ward round. So as we pass over to Hyogo in Japan, I'm going to ask Dr. Gianluigi Labasi, who should be online, to host the next part, and I'll join if the nurses don't kill me. Dr. Labasi.
Yeah, thank you so much, John. It's absolutely a pleasure to be here. I'm based in Brisbane. I'm an intensivist, a clinician scientist, and it's a pleasure. It's a pleasure to introduce Dr. Inoue from Hyogo Emergency Medical Center, which is a leading emergency trauma center in Japan. And the presentation is about the SAFE-G3 study. To you, Dr. Inoue.
Hi, can you hear my
Yeah, we can
voice?
hear you well.
Hello, everyone. Sorry. Can you watch my slide?
Yeah, you are not in presentation mode, but we can see your screen at the moment. Perfect.
Okay.
Yeah. Thank you
Okay.
so much.
Okay. I'd like to talk about ECPR for OH out of hospital cardiac arrest in Japan. In my presentation, I would like to introduce ECPR research from Japan. All right. ECPR is a resuscitation technique for patients with refractory cardiac arrest involving VA ECMO. Recently, ECPR has been increasing rapidly worldwide. To provide reliable data on ECPR in Japan, we perform multi-center study named SAFE-G2 study. Do you know SAFE-G2 study? SAFE-G2 is a retrospective multi-center registry study with 36 institutions in Japan between 2013 and 2018 with 2,157 OHA patients receiving ECPR. All right, I will show the several results from SAFE-G2 study. In the SAFE-G2 study, the main analysis focused on patients with presumed cardiac etiology. The median age was 60 years. 97% had witnessed cardiac arrest, and 58% had bystander CPR. Regarding initial cardiac risk, The main initial rhythm was shockable, following PA and SS3. The median time from call ambulance to hospital arrival was 32 minutes. Time from hospital arrival to ECMO pom-pom was 22 minutes, and estimated low flow time was 55 minutes. Next, regarding the outcome, febrile neurology outcome of hospital arrival was 14%, and survival rate was 27%. By initial cardiac rhythm, febrile neurology outcome in shockable rhythm was the best at 16.7%. PA was 9.2%, and SS3 was 3.9%. Survival rate was similar trend. Overall, complication during CPR occurred in 33% of patients, meaning that 1 in 3 patients has some complication. According to the data, which were duplicated, procedure-related complications was the most common, and cannulation-related bleeding was the most common hemorrhage complication at 16%. So, this study provided real-world data on CPR for OHCA in Japan. One strength of this study was its large number of ECPR cases. ECPR has been widely practiced in Japan for many years, which has enabled the establishment of this large registries. Another strength was that detailed data were collected in relation to indication, complication, and post-resuscitation care, which are crucial data when comprehensively evaluating ECPR strategies. So, an important topic when considering ECPR is patient selection. Regarding prognostic factors, I would like to introduce findings from the CEBDES study. First, transient loss. When transient loss occurred before the initiation of ECPR, it was significantly associated with both febrile neurology outcome and survival compared with patients without transient loss. Next, I will introduce the signs of life. Signs of life are defined as a Glasgow Coma scale, motor score more than 2 points, the presence of papillary light reflex, or gasping respiration. If at least one of these signs was observed at hospital arrival, it was significantly associated with febrile neurology outcomes. Both transient loss and signs of life have been highlighted in the AHA Guideline 2025 as prognostic factors, and these papers of our group are cited as supporting evidence. Including these papers, a total of 58 CEBDES sub-analysis papers have been accepted. Building on these findings, we are working on next projects named CEBDES study as the next research following CEBDES study. CEBDES study is a retrospective multicenter registry study with 54 institutions in Japan between 2019 and 2024 with 2,750 OHCA patients receiving CPR. It is not that the result and manuscript for CEBDES study is currently preparation. I will show the several results from CEBDES study. Among all registered patients, the median age was 60 years. 80% had witnessed cardiac arrest, and 63% had bystander CPR. Regarding initial cardiac rhythm, the main initial rhythm was shockable, and following PA and SS3. The median time from call ambulance to hospital arrival was 34 minutes. Time from hospital arrival to ECMO pom-pom time was 22 minutes, and estimated low flow time was 56 minutes. These data seem to be same as that of CEBDES study. Regarding the outcome, among the total patient registered CEBDES study, febrile neurology outcome at hospital discharge was 12.1%, and survival rate at hospital discharge was 26.7%. Next, I would like to compare the outcome of CEBDES and CEBDES studies. We have not yet performed a formal statistics analysis, but the rate of favorable neurological outcome was 40% in self-death study and 12% in self-death study, showing a slight decrease. Even when the analysis population in self-death study focused on presumed cardiac etiology, which was the same population of self-death study, the outcome in self-death study shows a slight worse. When stratified by initial needs, both favorable neurological outcomes and survival rate were slightly lower in self-death 3 than in self-death 2 for shockable PA and ACE history. Now, let's take another look at the data from self-death study. The left figure shows the temporal trends in outcomes. As you all know, the COVID-19 pandemic occurred during the study period of self-death 3. When comparing the period before, during, and after the pandemic, outcomes appear to be slightly worse during the COVID-19 pandemic and seem to improve somewhat after the pandemic. The right figure shows the trends in concomitant mechanical circulatory support with the ECMO. In Japan, Impera became available during the period. Over time, the use of IABP decreased, while the use of Impera increased. Self-death study provides real-world data on CPR or OHCA in Japan following self-death study. Outcomes of ECPR have not improved. This may be due to the impact of COVID-19. The use of Impera has increased. Outcomes appear to be improving since 2024, and real-world data from the next 6 years anticipate. Finally, I will introduce our ongoing research. Now we are conducting a trial comparing the temperature control between hypothermia and normothermia after ECPR, named self-death neurosum trial. In this trial, eligible patient is patient who underwent ECPR following out of hospital cardiac arrest. The design is cluster randomized crossover trial, so participant hospital will perform temperature management, pre-assign hypothermia at 33 degrees, 33 to 34 degrees, or normothermia at 36 degrees. Sample size is 464 patients. This project started in January of last year, and now the number of inclusion is 147 cases. This is last slide. Data on ECPR in Japan were presented based on the self-death and self-death studies. Future research is needed to clarify the true indication for ECPR and the optimal management after ECPR. Thank you so much.
Oh, thank you so much, Dr. Aniu. We might have just time for one quick question. Is there anyone? Otherwise, I do have a question, Dr. Inoue. Just in terms of the target temperature management, this is, of course, is in contrast with the evidence from patient non on ECMO target temperature management study 1 and 2 that they didn't provide benefit in the lower temperature. Why do you think that with the ECPR there could be some additional benefit? If you have a time for just a quick answer.
Thank you for your important question. My opinion is that if the hypothermia could protect brain damage, early cooling and stable temperature management is benefit for brain protection. So ECPR with heat exchanger can rapidly cooling and stable temperature management. So I think ECMO with heat exchanger to hypothermia is benefit for brain protection.
Yeah, absolutely. Yeah, the stability with ECMO in temperature management is quite different. Very good. So we move on with the next speaker. Dr. Katsuki Matsumara. Dr. Katsuki Matsumara is from Keio University. We'll discuss another important topic. And many times we need to decide if using ECMO is valuable in the geriatric population. So, Matsumara, thank you so much.
Thank you. Can you hear me? And can you see my slides?
Yeah, we can, and we can see your slide. Yeah.
Thank you. Thank you for your introduction. This is Kazuki from Tokyo, Japan, and I would like to talk about Japanese approach to VV ECMO in the geriatric population. I have nothing to disclose. My talk is about age and VV ECMO. ELSO sets no specific age threshold, but we all know that age somehow matters in VV ECMO. Using ELSO registry data, increasing age was significantly associated with poorer outcomes, but the relationship between age and mortality was linear and showed no inflection point. But this result was obtained from the ELSO data, including countries all over the world. So there's a question. Is the same trend observed in super aging countries? My home country, Japan, is quite a nice country, but it's also is the fastest aging country. This chart shows the percentage of the population aged 65 and over. As you can see, Japan is aging more rapidly than other countries and has the highest proportion of elderly people. And in detail, this figure shows the proportion and populations of the super elderly people, which is defined as aged 75 and older, from 1975 to the present and into the predicted future in Japan. The population of the super elderly continued to increase from the past to the present and to the future. And the proportion of super elderly was 14.2% in 2010, and now it became 21.6% in 2025, a 1.5-fold increase. This means that 1/5 of Japan are now become super elderly. That is a huge number. So here's the clinical question. How old is too old to perform VV ECMO? As an increase in super elderly in the population may correlate it with an increase in healthy super elderly. So is performing VV ECMO on super elderly patients contraindicated? To answer to this question, we performed an analysis based on the Japanese nationwide registry, which is different from the SAVE-J2 or SAVE-J3. It's called the J-COB registry. It consisted with 24 institutions in Japan, and it included adult patients with severe ARDS on VV ECMO from 2012 to 2022, and it included 688 patients in total. So this is a distribution of ages of VV ECMO in Japan. Median age was 60, and the eldest was 87 years old. The proportion of super elderly, which is age 75 years old or older, was 77.7% in Japan, and which is almost double that of the ELSO registry data, which is lower than 3.8%. The survival rate of the super elderly was 15.9% in Japan and 38.9% in the ELSO. This is the hospital survival by age group in Japan. Compared to the survival rate of the super elderly, which was 15.9%, the age group of 18 to 54 or 55 to 64 years old were significantly higher, which was 18.3% and 17.2% respectively. While the survival rate of the super elderly was comparable of that of the 65 to 74 years old group, which was a very interesting finding. And one reason for this result was careful patient selection. Generally, the incidence of comorbidities increase with age. This table shows a brief basic characteristics of our study, and as shown, the incidence rates of lung and cardiac diseases increased at age 65, but remained comparable between the 65 to 74 age group and the super elderly group. Also, the prevalence of diabetes and chronic kidney diseases or mild lung injury score before ECMO or SOFAR score before ECMO or PF ratio were comparable between all four groups. So in other words, relatively healthy super elderly patients were selected for VV ECMO. So this is our conclusion. VV ECMO in the super elderly in Japan, we had a higher proportion of super elderly than also registered data, but we had a very good survival rate, which was 15.9%. Also, it was lower than the age of very young group. So we believe careful patient selection is mandatory. So to answer the initial question, is performing VV ECMO on super elderly patients contraindicated? We believe it's no. Age alone should not be considered as a contraindication. So through careful patient selection, it is possible to achieve high survival rate with VV ECMO even in the super elderly. Thank you.
Oh, thank you so much, Dr. Matsumura. If there is any question from the attendees, I do have a question, Dr. Matsumura. So in terms of, and this is what we are learning also here in Australia from the Excel data set, it's important the characterization of this patient when they are in the hospital, but that has important the characterization of this patient during the recovery period. So the question is, what's your plan for continue the follow-up of this patient, because these I'm sure these are the patient are higher risk for potential poor recovery and lower quality of life.
So you mean after VV ECMO, you mean?
Yeah, absolutely.
Oh, yeah, that's a very important question. So in Japan, VV ECMO is often managed by the intensive care physicians or emergency physicians. And after the VV ECMO revelation, we mainly pass the patient to the pulmonologist. So we really not follow until the last time. So it's very important to, make a great conversation with the pulmonologist that they had a very difficult time during the ICU stay. So they really need a good rehabilitation. They had a post-intensive care syndrome. So it's very important to, deliver the information, communicate with the pulmonologist to, make the patient recover to their normal lives.
Yes, absolutely. There is a question from Pauline Young. How you selected the super elderly? Did you use frailty score as well, comorbidity score, or do you actually have milder illness? And this is absolutely a concern from everyone, because we do have very good elderly people, but in particular in different countries than Japan, we do have patients who are not that healthy when they reach that age.
Thank you for a good question, Pauline. Yeah, this is a real world data, so we actually don't know how each facilities had chosen the super elderly people to, introduce VV ECMO. But in my facility, we just not look at the ages. We look at performance status, like how they spend their daily lives at homes. They, they should, have the normal daily life before choosing to introduce VV ECMO. Like the patient on the bed every day is not a potential we don't do VV ECMO to those kind of patients. So we communicate well with the families to know their how they spend their daily lives, and we have to check their, of course, past medical comorbidities, of course, and we should know is there any other severe organ failures, like if they have a severe chronic kidney diseases, or they don't have maybe like difficulty of managing diabetes. That is not a potential people to have a PP ECMO. So yeah, communicating with families and other doctors. And at the last time, we always don't decide by one physician. We all have a discussion with other physicians and nurses to finally decide to initiate PP ECMO. I think that's the most important thing. Thank you.
Yes, absolutely. So I do have now for Dr. Inoue from a previous talk about ECPR. If he's still online, of course the importance of characterizing and keeping a very large data set in ECPR is one of the most important action that we can continue in order to move forward with the CPR. The data that you showed us are quite critical, particularly the static mortality that we are experiencing not just in Japan but everywhere. Japan is leading because of the number of ACPR cases that you guys have over there, but the mortality is quite poor worldwide. Now, I would like now, if there is no other question, we would like to move from Japan to South Korea. And it's absolutely my pleasure to introduce Jae-sung. Jae-sung is a colleague and a friend as well, because from Korea Medical Center in Seoul, he is a cardiothoracic surgeon with extreme expertise in extracorporeal life support and heart transplantation as well. And he spent time with us over here in Brisbane at the Critical Care Research Group, particularly contributing to the translational and preclinical research that we have here in Brisbane. And today he will speak about particularly still on ECPR, on neurological prognosis after ECPR, and cost-effective analysis of the ECPR in South Korea. Again, Jae-sung, it's a pleasure to introduce you.
Hi, Gianluigi. Can you hear me?
We can hear you very well. Yeah.
My slide is also show you?
Yeah, we can see the slide.
Okay, thank you. Great pleasure and great honors. I have present my slide, my talk for Bartlett. It's my talk. I am Kazakh surgeon. My name is Jae-sung Jung. My talk title is the neurologic prognosis with a biomarker after ECPR and then cost effectiveness analysis in South Korea. I have many memory with Bartlett. I just showed many photo with him and Harding and then Lotus right there. So as you know, ECPR is important. Many candidate and insertion training is important, but another part is the post-resuscitation care. So last year, European Resuscitation Council released this guideline. There is one part is they focus on usually multimodal strategy, including clinical examination, EEG and biomarker, and the imaging. So I introduced that there are so many EEG, SAEP, biomarker, and the clinical examination and imaging they introduce. So my center is my colleague is focus on the biomarker nowadays. So as you can see, and the poor so we are not very well known about that. It's in no pupillary and the conical reflex at 72 hours or later, and then and so on like that. And neuro NCE higher than 60 microgram, and then at 48 hour or 72 hour, shorter than 4 outcome like that. And another part, good neurologic outcome, like the good GCS score and then good EEG spike like that. And then NSE is lower, that make show the good neurologic outcome, you know. So this paper is very important. Last year, research station showed that this one. And in case of ECPR patient, assessment after 72 hours, after 3 days, they systemically underestimate recovery. So we have to wait 3 days. As you know, inception trial, they are usually just 1 day, they withdraw the ECMO from the patient. So I think we focus on this one. So I moved to biomarker for neuroprogression. So in the past, many of studies about the NSE. NSE showed the enolase means one of the step in the enzyme glycolysis process of the cell. So NSE as a predictor of death or poor neurological outcome after out of cardiac arrest, and the target TTM and 33 to 36 Celsius degree. So many of study release NSE can be a predictor of the neurologic outcome. So, but NSE have some limitation because of usually it's a pre-ECMO cause hemolysis, but NSE is effective at that kind of hemolysis. So usually the decreased trend of 22 hours to 72 hours, that means 82% positive predict value for favor outcome for neurologic recovery. Another biomarker, that is S100B and then tau. So it's a recently released guideline. So neurofilament, that is a very good biomarker for predicting neurologic outcome, because this is less susceptible to hemolysis and the circuit interference than NSE. So at 24 hours, the level of the NFL, so over the 2000, there's a 100% specific for outcome for neurologic recovery. Then below 55 picogram, that means a strong predictor of good prognosis. So this is an optimization of the timeline. So after ECPR at 24 hours, S100B and the NFL, we have to check. And then at 24 hours, we check the GFA, AP, and then after 3 days, we check NSE, like that. We can predict the neurology outcome. Recently, we released one study with the Hopkins group. So this is a preliminary study, but it is also show the NSE is also show the predictor for neurology outcome, and then we show the predict the AUC curve and the cutoff value. And then now we undergoing serum biomarker study in ECPR with the Hopkins group and then my group. So we focus on 3 biomarker: neurofilament NfL, and then tau, and then glial fibrillary acidic protein GFAP. So now we are all ECPR patient with IRB permission, and then we collecting full serum sample, and then gathering and then send to full sample to Johns Hopkins by FedEx. And then now we undergoing the study, and we can collect the data. We analyze in one center in Hopkins. We can get the good value, and then we can conclude this biomarker will be good things. So multimodal framework for neuroprostication. So as I told you, EEG and SASEP is malignant portion. Many of them you guys know that first suppression at over the 24 hours is bad malignant prognosis. And then CT scan early phase and MRI after 3 days showed you can predict the neurologic outcome. In Hopkins could already published this one, portable MRI in ICU with ECMO. They showed a safe in ECMO patient also. So multimodal framework demands the two marker confirmation. So in case of this one, bilateral absent pupillary corneal reflex at 72 hours, absent N20 on SSAP, highly malignant EEP, and over the 60 microgram in NSE and diffuse edema in CT/MRI. That means a poor outcome cluster. So how we can reducing prognostic uncertainty by ruling and recovery. So you can estimate like a Dixon, what is a good recovery of neurologic things. So as I told you, you have to wait in case of ECPR at least 3 days. And then after that, many of patients can recover. So in the future direction of ECPR patient, personalized medicine and hemodynamic target. So autodynamic analysis is easy like that, and then biomarker study, and then hemodynamic optimization after ECPR things. So you shift window until 72 hours, recognize late or wake up, and then prioritize kinetics like a trend trying to observe value, and then only check the biomarker like NFL, and then another biomarker we have to find to predict neurological outcome. So final thought is ECPR require distinct prognostic approach to match its distinct physiology. Resist premature withdrawal life support things. You have to avoid like inception trial the error like that. Second things we just unpublished data. This one we submit this one's US abstract. Very short things. This is the nationwide study in National Health Insurance System data. So as you know, in Korea and Japan, so many ECPR patients, but despite this clinical promise, but evidence on the cost effectiveness in ECPR in the real world is very lacking at the evidence. So I received the funding from the government. I analyzed. So this based upon this data from the National Health Insurance Service, the adult patient, and the 1:2 matching ratio, propensity score matching. In hospital versus out of hospital, age group is 44, below 44, between group is 45 to 64, and then over 65. ISO means incremental cost-effective ratio. So this is survival benefit is a matching below 44 and below 64. significantly higher survival rate in ECPR, out of hospital and in hospital also. Over the 65, yeah, not significant result showed. Cost effectiveness, we matched what is 2,601 to 12 patient. Medical cost significantly higher in ECPR, as you know, but survival benefit 2.5 life year gain, 2 year more live in ECPR group. Mean total medical cost 3 to 5 times higher in ECPR group than ECCR group. And then, as I told you, ECPR group is 2 years more live than CCPR group. So this means we studied this previous study until 20,000 US dollar below. That is good, but over the $20,000, that means not cost effective. So most favorable below 44, but over the 65, that is reduced cost effectiveness. But this study have many limitations, but until now, ECPR demonstrates favorable economic effectiveness in younger patients. But depends on this study, our government, we discussed with our government, and we need to change the policy and then manage over many things with our government. Thank you for your attention.
Oh, Jae-sung, a very, very interesting presentation. And we do have a few minutes for a question from the audience. If anyone has any question. Okay, so let me start, Jae-sung. Now, every time, and we are dealing with inflammatory or any other biomarker for prognostication in Australia as well. Every time we have new biomarkers that are promising, and we are very excited during this convention about these biomarkers, then in the next 5 to 10 years, we go back to the clinical practice, and we always have this impression that we are stuck at the very early stage of prognostication. You mentioned several biomarkers. NSC has been there forever. S100B as well has been quite investigated. And then the other more NFL or GFAP, they are a little bit more new, but we are always struggling in understanding why the biomarkers and the information from the biomarkers are not easily translatable in the clinical practice. And clinicians still do not rely, even in good biomarkers, in their decision making. So what's your take on that? And the second question is about cost. Many of these biomarkers are not measured even in Australia due to the cost. So what's your take on these two questions?
Yeah, very good question. As you know, to analyze these biomarkers needed so many money. So that is a clinical obstacle to apply this biomarker. You can get the result needed and the time also. So so we collaborate our biochemical research team in our university. That they made one company. So then we collaborate with Johns Hopkins. We try to reduce the time to get the result, and then the price also, but still very high research funding needed until the research level. But that is a limitation. The price so expensive, not yet apply to the clinical because it's so expensive. So, but increase the number of the company and then the materials, we can reduce the price, and then in the future we can apply to clinical that I think. And then
Yeah,
the
of course.
things, so many things, the biomarker, which one is the best one? We don't know yet, but we have to find we have to find which one is the best one. So we can nowadays we collaborate with the Johns Hopkins just three things because it's so expensive. Just find the three things also needed so many money. So after that, we try to more funding, and then we try to more biomarker we tried.
Yeah, and if I can comment on the field of investigation, we do need, in order for the policymakers, in order to understand at the hospital admin level, understand the value of biomarkers in our clinical practice, we do need evidence that clearly compare the cost of ECPR with or without biomarkers, or with any other new strategy for prognostication, because ECPR is a quite expensive technology, and the prolonging of the ECPR support in some cases absolutely it's going to increase the cost without benefit for the healthcare system. Yes.
Yeah, right.
So, Jae-sung, it's always a pleasure when we have you in our sessions. It's my pleasure also to introduce now Dr. Wai-Chin Cho from Chonon National University Children's Hospital. She's a clinician, brilliant clinician scientist dedicated to pediatric critical care, extracorporeal life support, cardiologist, and like Jae-sung, has been a pleasure to have her here in at the Critical Care Research Group in Brisbane. And today, specifically, she will present something. I'm an expert in preclinical investigation, so I will enjoy your presentation. From vision to reality, translation animal models of ECMO, bringing it to heart and lung transplantation. And this is a specific presentation in honor of the biggest name, Bob Bartlett.
Hi, everyone. Good morning, good afternoon, and good evening. This is a privilege to speak here and to be part of this session honoring Dr. Robert Bartlett. My name is Wai-Chin Cho, and I'm a pediatric cardiologist from Korea. And today I'll be talking about the translational animal models of ECMO bridging to heart and lung transplantation. Can you hear me well?
We can hear you very well, yeah, and we can see the slides.
Before I begin, I'd like to take a moment to acknowledge Dr. Bartlett. He was a mentor to many of us and also to our entire team. And in preparing this talk, I found myself reflecting on how much of our work has been shaped by his encouragement and guidance. And I am so grateful for that. And in some ways, I think of this presentation as sharing some of our work back to him as a reflection of what his guidance has helped. So our research group, Excite, has been grown since we met Bob. And on the left, our clinical team, and on the right, it's our research team. And we have been involved in a range of ECMO-related research area, from device development to organ-specific investigations. However, today I'd like to focus on one aspect of our work, small animal ECMO model. Our group is still working on small animal models, even they don't 100% mimic clinical scenarios, because it is easier to have molecular level of studies with small animals, and we can also do the preliminary testing during cannula or oxygenated development. When I first presented our small animal ECMO model, it was best abstract session where Dr. Bartlett was moderating and where I received an iPad. And several years later, in 2023 in Seattle, I had an opportunity to be in the same abstract session with Bob, and this time as a moderator together. That was a meaningful time for me. And what I remember most was his approach to the session, how carefully he listened, how thoughtfully he asked questions, and how much attention he gave to each presentation. And was a valuable experience for me. I learned a great deal from him. In Austin, the work I presented focused on rat ECMO model. In this model, we ran ECMO for about 2 hours, and after decannulation, the vessels were ligated. And what we observed was that the animal were able to survive despite that process. And building on this initial model, we were able to expand the platform and subsequently published several studies using similar approaches. And in this published study with the rat ECMO model, we identified the immunological changes following both VA and VV ECMO exposure. We then extended this platform to disease model like septic shock to better understand how ECMO actually interacts with underlying critical illness. And more recently, we have worked on improving the VV ECMO model. In Korea, our team is working on developing double lumen cannula for clinical use with National Fund. And based on this concept, we adopted the idea for small animal models. And by combining central venous line for drainage and PICC for perfusion, we developed a small animal double lumen cannula system applicable to VV ECMO experiments. And this approach simplifies the surgical process and improves feasibility and reproducibility. In clinical practice, we often encounter patients who are supported on ECMO but do not recover and eventually require heart transplantation. However, outcome in these patients tends to be more challenging. And there are still many unanswered questions about how to optimize their managements. And this has led us to think about whether there are ways to better understand and potentially improve these outcomes. And to address this experimentally, we expanded our platform to include organ transplantation models in small animals. We first developed a reproducible and feasible heterotrophic heart transplantation model, and our initial focus was on establishing reliable and standardized technique, which we published in video-based format. In addition, we established Excito heart perfusion system, which allows continuous evaluation and preservation of donor heart function. And we further explored optimal perfusion conditions, including temperature and perfusion pressure, to better support graft function. For a similar reason, we also expanded our work to lung transplantation models. Using a rat model, we developed a reproducible platform with particular focus on standardizing a surgical technique. And this allows us to explore how ECMO support may influence lung graft function. And this work is still ongoing, and we are currently preparing it for publication. So my ECMO research career began in 2013, and since 2016, I've been fortunate to receive continuous national research funding without interruption. And as we prepared new research proposals, I very, very often reached out to Dr. Bartlett for advice. And even when my questions were not always well structured, he never failed to respond. and he always inspired me in many ways. The last time I saw him was in Ann Arbor in 2024. I believe many of us here share that moment together. And this past winter, I returned to Ann Arbor with my child to attend his life celebration. And it was a meaningful time to remember him together with so many people who care deeply about him. So in many ways, our work represents a small continuation of path that Dr. Bartlett began. And we all miss you, Bob. Thank you.
Yes, Dr. Cho, we do miss her very much. Excellent presentation. Any question from the audience? Now, watching my question as expert in preclinical experimentation in large animals might be naive question, but I try to understand the capability of the models in comparison with large animal models as well. Now, one of the question is related to the potential of genetically modify rats or small animals, because that would be we cannot do that in pigs and sheep. It's quite difficult, but application of CRISPR, application or development of transgenic rats to look at specific response and control of the response in this model, I think it will be crucial. What's your take on this? And do you have any plan of using any genetic modification of these models?
Well, thank you, John Rizzi. That's the way we are going to expand our experiment. And at the moment, we are working on actually in mouse model, because with a mouse, we can actually buy those genetically.
Yeah.
Yeah, those. So in rats, it's quite difficult to make that kind of model. But well, I think in near future, we can make mouse model and expand our experiment to that way as well.
Very
Thank you for
good.
your question.
Yeah. Sorry, go ahead.
No, that's it. That's all. Thank you.
Yeah. And the second question I always ask, because I enjoy when they ask me this question, what are the specific limitation of your models? What we need to know about, of course, the size is the first and foremost limitation. What are the other limitations that the audience should know about these models?
Well, it's not always clinical relevant, so we always have to interpret it carefully, and therefore we are like more focusing on molecular or immunological things rather than clinically hemodynamical things.
Yeah.
The limitation of this model is we need some time to get trained. And I am a pediatric cardiologist, so I am more used to these small vessels, and the venous drainage catheter we used is actually the neonatal feeding tube, and we have modified this neonatal feeding tube. And the idea came because I'm one of the ped doctor, and well, if you can learn like that surgical procedure, I think it's not difficult. Quite many of our researchers are doing it by themselves now.
Yeah.
I think they're
Very
easier
good. Very
than
good.
before.
Very good. We look forward to potential visit to your lab as well. Okay. It's time to move on. Thank you so much, Dr. Cho. And now from South Korea, we will move to China for two excellent presentations. The first presentation is from Professor Ho from Beijing Cancer Hospital, and he will talk about from inspiration to action, how Bob Bartlett strongly, we are certain that strongly influence ECMO in China. To you, Professor Ho. Professor Ho, I think we cannot hear you. I think you are on mute potentially.
Can you hear me?
Oh, we can hear well now. Okay, very good. You can share the screen back again.
Can you see me?
Is loading up. Yes, perfect. We can see it as well. Thank you.
Thank you. Today, I want to share a story not just about technology, but about a person and how his life work changed the course of ECMO in China. Robert Bartlett, the father of ECMO, he passed away on October 20th, 2025. And Bartlett began his ECMO research in the mid-1960s as a young surgeon resident in Boston. In 1971, he reported the first adult ECMO survivor, published in the New England Journal of Medicine. In 1975, Baby Presenza became the first neonate ECMO success, a moment that changed everything. He built the ECRS research laboratory at the University of Michigan in 1980, and in 1989 founded ELSO, which today connects 750 member centers across 66 countries. When he passed away, over 100,000 lives has been saved through ECMO. 54 years of continuous NIH funding, one man, one question, one mission. My own journey with Bartlett began in 2007 when I visited the University of Michigan. What struck me was not just the machines, it was the model. A dedicated ECMO team serving the entire hospital. I brought that model back to Anzhen Hospital, to Beijing, to China. In 2009, Bartlett made his first visit to China, speaking at the fourth annual Congress of the Chinese Society for Extracorporeal Circulation in Chengdu. For many Chinese practitioners, it was the first time they heard him speak in person. Then in 2013, we hosted the first AP ELSO Congress meeting in Beijing. I took Bartlett on a tour of the city. The relationship moves beyond the academic. He became a mentor and a friend. Back in China, we carried out one clear conviction to build not a team, but a system. That became our guiding principles, captured in one phrase: from reactive to proactive, from ad hoc to organized. In 2013, we established China's first national ECMO forum, bringing together centers from across the country. In November 2014, we published the first national experts' recommendations on setting up an adult ECMO program, the foundation for standardized care in China. By 2017, CSECRS was formally founded under the Chinese Medical Doctor Association. We structured the training, rolled out systematically across all provinces throughout China. And in 2020, when COVID-19 hit Wuhan, COVID-19 patients were supported firstly by ECMO in the world. Building the community was one challenge. Building the clinical system was another. To build reliable, timely, and safe bridges across the most critical moment of China, we face 4 core problems. ECMO takes too long to establish. Complications are frequent. Decision-making is difficult, and winning is unpredictable. To address each one, we develop a complete technical framework from rapid cannulation and equipment development and to superior vena cava drainage, to mortality prediction models, to individualized weaning protocols. The results speak for themselves. 1 year and 5-year survival rates are well above the international benchmarks, praised by many international colleagues. Building on Bartlett's blueprint, we set out to replicate the model in China, establish association, building a training program, expanding the network, and pursuing excellence in every center. Since 2015, we've had trained over 500 practitioners nationwide, covering more than 30 provinces through more than 30 CSECRS certified training bases. In 2021, Beijing Anzhen's Hospital was awarded the also Gold Level Center of Excellence. It was a recognition not just for our clinical outcomes, but for our commitment to education, collaboration, and the promotion of ECMO across China. From July 2025, the 7th APLSO Congress back to China and was successfully held in Beijing under the theme Bridge to Life. The Congress united leading ECMO experts from around the world to share the latest advances in extracorporeal life supports, sparking meaningful dialogue on clinical innovations and regional collaborations. As the curtain fell on these landmark events, heartfelt thanks were extended to all international experts from their unwavering support in advancing ECMO development in China. The numbers tell the story of transformation. By 2024, the number had grown to nearly 23,000 cases per year across 930 centers nationwide. Survival rates have also improved steadily, 55% for adult pulmonary support and 51% for adult cardiac support. You can see on the chart that a significant inflection point occurred around 2013, the year of APLSO, the year the community truly came together. Growth has been exponential ever since. The CSECRS registry started in 2016 with a simple goal to track ECMO cases across China using the same standards as ELSO. By 2017, the system was live. Over 150 hospitals began reporting data. By 2018, CSECRS training was officially certified by ELSO. Today, the registry have grown to over 18,500 cases, covering more than 150 centers nationwide. The results are encouraging. Nearly 79% of the patients were successfully weaned from ECMO, and overall survival rates reached 51.8%, with outcomes improving every year. And the data is beginning to put to work, powering 14 published studies, 12 submitted papers, and 15 ongoing research projects. Our clinical work has produced research that has influenced the global ECMO community. We want to devote it to this community. 3 early contributions stand out. In 2015, we published on differential hypoxia, identified the mechanism behind upper body hypoxia during VECMO, and proposing superior vena cava drainage as a solution. In 2018, we reported our experience with prophylactic distal limb perfusion, reducing limb ischemia to 5.6% compared to more than 60% reported internationally. And in 2019, we introduced the Remember score, a 6-parameter bedside tool to predict mortality in VA-ECMO patients after CABG, outperforming SOFA, SAFE, and Euroscore. More recently, 3 further publications have extended our impact. In 2025, CSECRS published the National Clinical Practice Guidelines for Trauma ECMO in adults, 11 evidence-based recommendations to standardize bedside implementation across China. Also in 2025, our research showed that achieving a simple physiology bundle with 24 hours improved survival and reduced major complications significantly. In another study, we demonstrate that hyperoxia during VECMO, even at moderate levels, is independently associated with acute brain injury and increased mortality. We are not stopping at the observation. 3 prospective trials are currently underway. The ECMO-ready trial will determine whether standby VECMO is superior to prophylactic use in high-risk PCI patients, providing the evidence base to standardize practice in this high-risk population. The EASE ECMO trial will study on CS ECMO patients to test whether adding balloon pump for left ventricular unloading reduced 30 days mortality and improves successful weaning, addressing one of the most debated questions in cardiogenic shock management. And the HOPE CS trial will evaluate a bundle management strategy in cardiogenic shock ECMO patients, aiming to create a reproducible protocol that can be scaled across centers. Bartlett gave his life to one question: how do we keep more patients alive with ECMO in more places with better outcomes? That question has shaped everything we have done in China, not just built a team, but building a system, so that the answer could reach anywhere throughout China. His blueprint has guided everything we have built in China. We heard it, we acted on it, and the work continues. Thank you for your attention.
Thank you so much. Thank you so much, Professor Ho. Let me tell you that it's been very moving to hear how Dr. Bartlett Legacies is actually translated into the development of an entire technology across China. And we're talking about a country with a population of more than 1 billion people. So I think this is a real inspiration for all of us for what Dr. Bartlett has created. Now, if there are any question from the audience, no question that I can see. Otherwise, I do have a question. Now, Professor Ho, this might be a difficult question. Where do you see the technology, the ECMO technology in China from now to 10 years? What are the specific things that is going to inspire you and China in the next 10 years?
It's a very good question, and I think ECMO changed a lot in China because ECMO not only a technique. When you use ECMO, you can see a lot of etiology of the disease itself. We will use maybe for the VV ECMO for ARDS, you can see not the ECMO make the patient survival, but the protective lung protected technology. So, and also when we use ECMO, the whole system of the Chinese hospital will the management was changed. We can save a lot of patients that doomed to death, and we also change the administration. Some, for example, when we save the COVID-19 or SARS or H1N1 without ECMO, we only use the mechanical ventilation, but we use ECMO, and we have the further treatment for the patients. And also in next 10 years, ECMO technology, I think it's not the only technology. Now we are also introduce Impella and a left ventricular assist device, and also heart transplantation in China. So how to even the balloon pump in old days, but we now will maybe a combination of use all these kind of mechanical circulation support technology together to improve a patient's life.
Thank you so much. Thank you so much, Professor Ho. Let me pass over back to John Fraser, who is going to introduce the next speaker. Thank you so much.
Okay, thank you.
Luigi, thank you. And say, Dr. Ho, I think in this time of craziness in the world, the science is phenomenal, and I'll be really interested to hear about the EASE ECMO study. Jean-Tong, we're doing the same in animal models here. So perhaps offline we can share some ideas if we can help you in the preclinical model as other questions. So again, Quentin, who Alain Combs gave us a loan of from Paris, has come to Australia and happy to collaborate with China. Just before we pass on to Dr. Long, who's going to continue with the presentations from China, and how lucky are we to have China, and the numbers that China brings to ELSO are phenomenal. I showed this picture at the, now if I start sharing the screen, no. There we have it there. Sure. I showed this picture at the start, and of course, no, sorry, wrong. I showed this picture at the start, and it's an important picture. I think the science is important. It's wonderful going through all the science that we're doing. And this is a picture of Bob at the one of the first pictures where we all got together after the COVID pandemic, and having run the consortium, 40 plus papers, brought brilliant young scientists, including Martin Urner from Canada, Pauline Ng from Hong Kong, so many different people working together. And it's the bringing together. The science is important, but so is also the bringing together to bypass global politics, so that The patient is put at the forefront, and bringing people together over bread and wine is fantastic. And I think this is a great picture of that wonderful AP-ELSO meeting that we had in Beijing, which Dr. Hao Lan, and this is a great picture because it shows, number one, how hard China can party. But what we actually had in this picture was Hong Kong, Taiwan, China, and Japan. So the whole of Asia working together, partying together, and having one common purpose. And it doesn't really matter who your politician is. The patient, as Bob always taught us, was the forefront of what we should do. And I think this summarises what Bob and what ELSO continues to do. So it's Xie to Dr. Ho, and now we're going to move on to our next speaker, and that is Dr. Long, also from China, who is from the Peking University. So, Dr. Long, we will let you take the stage, and I will. I've got a little bit of stuff to talk about why Asia Pacific is leading the charge in global ELSO. So, Dr. Long, over to you. Thank you.
John, I don't see him on, but maybe I don't see the name.
Okay, just see if Lauren.
Maybe you can move on. I will take a call, make a call.
You give him a WeChat.
Yeah, maybe he's missed the timing. Yeah. Okay.
Well, what we might do, I have a presentation I was going to close with, which we might not use then. I'll just see whether Dr. Long, getting texts coming in as we speak. So just as before we do that, we've got a question, Jiatong, from Pauline in Hong Kong, congratulating you on the amazing system that's been built in China. What strategies would you use to help align standards and practices in a country that is just so vast? You know, that the size of China is amazing. It means that you can proceed at a tremendous rate of knots that you do. But how do you standardize practice in a population so big where your patients are so heterogeneous? Tong, you still there? That's a question for you. Okay, we don't have him online. Okay, so then what I'll do is I am going to. Oh, he's probably, yes, a fair point. He's probably on the phone trying to. Look, I'm going to kick off, I think, with a presentation about why Asia is going to lead innovation in the next century. Not to be confrontational, but seeing as we are representing Asia Pacific, unless I hear from someone else that he is ready to join. Let me just kick off, and if Dr. Long joins us, I will just stop talking. Most of you know that's not true.
I'm sorry, Joe.
Oh, hi. How are you?
Dr. Long have a very serious meeting.
Okay.
He will miss this meeting.
Okay, that's fine. I will take over. But just whilst we're waiting, I'm going to present next then. So we had a couple of questions for you from both Hong Kong and I think Australia. So Pauline Ng, who you know well, was congratulating you on the amazing system that China's got. But how do you manage to standardise ECMO? We know how important education and standardisation is. How is that possible over a population of 1.5, 1.6 billion people, please?
Yeah. We set up association, and then I was always thinking how to make that whole country can use this ECMO technology to all the patients. So we set up a very simple training course, 1 or 2 days to let the doctors know how to priming, how to use the machine, and how to cannulation, and what's the indication and contraindication, and some basic indication for the VECMO or VVECMO. This is the first course, and then we will hold principal teaching for 2 days based on the Red Book, and he will for those doctors who did several cases of ECMO, and then he will know the principles series of the ECMO, and then we certified more than 30 training-based hospitals, and they have a lot of ECMO cases. Maybe can share their experience to the trainer. So these 32 training bases across China in every provinces, and doctors will get training there, clinical training there for 3 months, and so they will know how to use and in the real world, and then after that they will have some connection with their teachers and with the experienced doctors, and they will carry on their own ECMO program. So this thinking, this thought is come from Dr. Bartlett, and he told me maybe doctors will get the clinical training in some experienced centers and get the technology and also the relationship with their experienced doctors, and can guide their ECMO practice in their own hospitals. So this like frame, it's a lot of we under this system we are training more than 500 doctors, and their own they came back to their hospitals. They will training a lot of ECMO practitioners. So this move on, and so so ECMO in China grew up. Yeah.
Lovely. Great answer. And as you say, 500 doctors the size of China is quite mind-boggling. From Dr. Suen, Professor Suen, looking forward to the EASE ECMO. You maybe missed Cantam from Napitié. We're now doing an animal study with an ejection fraction of 20%, and we're looking at pulse ECMO versus continuous and balloon pump. So essentially what you're doing in the EASE ECMO, but in a standardized model. And of course, we're always happy to bring down some of your students to work alongside them. And Dr. Ho, without being rude, to teach them how to sing even better than you teach them how to sing. So they are always welcome here in Brisbane. But Jackie's comment is, what is the most common current LV unloading strategy used in China at the moment?
Yeah, we are saying in the world literature, balloon pump is the most used technology combination with ECMO, but I think the effect of a balloon pump is very little, and we always use the second is post-cardiotomy patients. We will directly drainage the left atrium by cannulation. And for the cardiogenic shock patients, we will use the septotomy to release some blood from the left atrium. And we are not use the impeller to drainage the left ventricle because the impeller was just introduced in China. So we also use we use is the left ventricular unloading is use the volume reducing. So use the medical method to do that. Yeah.
Lovely. Yeah, no, I think you're right. I think we don't know enough. And whether it's in the animal model with our standardized work with Lapetier and yourselves in China, we'll be able to learn some more. So we haven't heard from Dr. Long yet, and I know thanks, Howie, for checking in on him, but it looks like he's perhaps been waylaid. So I'm going to take the chair's privilege and talk a little bit about, before we hand over from Asia Pacific, going to talk, just waiting for that slideshow, there we are, talk about why, as we pass over from Asia Pacific, and thank you very much to the multiple countries, Korea, Japan, Singapore, the Philippines, Australia, New Zealand, that have all presented. But I think a tour de force by our team here, and I think it speaks for itself that Asia Pacific is going to lead ICU for the next century. And there's a number of years behind this. When we first presented, it was the year of the snake. When we presented this in Beijing, in Dr. Howe's fantastic centre. And now is the year of the horse. This is an Australian horse called Farlap, who won a whole pile of races. But we align ourselves, although perhaps don't look too Asian, we align ourselves very closely with the Asia Pacific because this is the biggest growth area in the world, and Australia is happy to work alongside both either the horse or with the snakes. And we know that Australia has more poisonous snakes than any country in the world. All of these exist here, so I'm quite surprised we haven't used ECMO more frequently than we have heard for myocarditis. So the current global situation, I think, is pretty dire. If we look at the things that are happening around the world, there's global warming, there's wars, there's droughts, and the economic uncertainty index is just rising more and more. And it's a very sad time. We can look through all those things happening in different points, and we haven't even started looking at the last 6 months. But uncertainty is rising. There's political uncertainty. And then there's also financial uncertainty too, and it continues to rise across the world and also in a regional manner as well. And again, we could have updated this slide, but thankfully we haven't. And in terms of, this is a sad slide, but don't worry, this talk's going to get happy. This is the areas where there's wars, and again, this was 6 months out of date, but there's wars happening in all these different places. And if you look at that wonderful research group, Iron Maiden, they wrote a song called 2 Minutes to Midnight, and that was released in, I think, the 1980s. But if you look at the doomsday clock statement, if we look at the world in terms of timing, and this goes back to the 1945, where Einstein looking at the world, how long the world was going to last. So in 1947, they reckoned it was about 7 minutes till midnight. 7 minutes to midnight was the arbitrary setting just after the Second World War. And then it, got a bit worse when the arms race kicked off. The Americans and the Soviets started using hydrogen bombs, but things started to peel back when the warmongering was reduced, pull back even further when there was less weapons, pull back even further in the early 1990s. And unfortunately, things started to speed up as countries started to fight, and then down to 89 seconds to midnight with the risks of nuclear war. So from politically, I think we have got many concerns at the moment, but what I think we have got in this group in terms of ECMO, but also ICU practice, we also have significant clinical uncertainty, so we can't just tease the politicians, because all these different areas we think we know about, and we're talking about VV, ECMO and ARDS. So we see what, as a global condition, ARDS, and these are the official guidelines from the American Thoracic Society, which read well, and then the European guidelines come out, and then the global guidelines come out. So there's 3 different sets of looking at a condition that we kind of think we've got the hang about. and we need to do better. And that was the question to Dr. Ho about how do we manage across Asia-Pac or across China to get standardization, but we can't even do this across the rest of the world. And our good friend Luciano Gattinoni said definitions, guidelines and opinions, the white, the black and the grey, and here he is with Antonio Pacenti, and he's quoted as saying it is therefore worthwhile to question the real value of guidelines when two societies have such marked different recommendations. So if we look at some of the studies that come out of our own area here in Australia, and the FARLAP study that we were all involved in terms of opening the lung, didn't improve survival. In terms of adrenal, the New England Journal study run by Bala Venkatesh, steroids and sepsis, no improvement in survival. In terms of the SPICE RCT, no change in survival. And in terms of early mobilization on ECMO, run from the Excel with Carol Hodgson running that, no change in survival. So there's lots of studies, again, with the team, just to finish. So we need to understand, I would suggest, more mechanistic studies. But I think if we look at Asia Pacific, and this is me getting my hobby horse of supporting Asia Pacific, it's not all bad. And the question really is, how well is Asia Pacific performing? Firstly, my postdocs are performing very poorly. This is their idea of what I look like in terms of a teacher for the intensive care. And, you know, Asians, and again, that was created by an Asian student, so I'm allowed to show this slide. Asians are very obsessed about coming first and getting the best marks in the classroom. The phrase Asian parent is used widely in Australia. So I guess the question for us in Asia Pacific is, how are we performing in terms of mathematics? We've got a huge population here, 4.8 billion people, a huge labour force, and that is tremendous potential to run studies. And China, I think, leads all of us in terms of running things at scale with that huge population, some great doctors, nurses and allied health. And if you look at COVID, we talked about it before, they were building 2 hospitals in 2 weeks when COVID kicked off, and I don't think that would be possible anywhere else. So in terms of maths, I think you'd have to give China and Asia Pacific an A+. In terms of technology innovations, well, I think there'd be very few places ahead of it. Digital transformation, machine learning and digital platforms. This is the use of smartphone by different countries, bearing in mind China and India both are in the Asia Pacific domain. So the use of smartphones, which are really just small computers, just is phenomenal. In terms of countries by exports, again, China dwarfs everything. The most innovative places in the world is basically run by mostly Asian countries. So again, they get an A+ for that. In terms of science, well, you know, science, I guess, would look at America as one of the leading places, and we can look at the science team from America. And without being too descriptive, there's very few Caucasian faces in the US Earth Science team. Young Malachi Noel does very well to get in there, but the Asian diaspora has traveled long and hard, both in terms of the science team. And then if we start looking at other scientific teams representing the United States, the Asian diaspora, again, continues to do well. And this is the maths competition. And of course, our own Jackie Suen. So he gave himself an A+. So science, again, Asia is well ahead. In terms of economics, the workforce here is phenomenal. It's got the ability to trade and manufacturing. The consumer class is increasing. And at the moment, however, the GDP spent in healthcare is much, much less than other nations. And this is a nice graphic that shows that it's relatively poorly funded to that. So again, A-, we can definitely do better, and I think it's happening. But if we look at the change in GDP over time, Asia-Pac is really increasing substantially. And this is reported, if you look at the Nature Research Index, China now employs more researchers than both America and the entire European Union combined. This is a slide put in by another of my team showing that Japan, so we're not just focusing on China, Japan beat Scotland recently. I think it was a bit lucky. Arts and music, I don't think we have to talk much about. Boy bands, the arts that has been around for many, many years is phenomenal. We have a huge diversity, but it's also difficult because our teams struggle in terms of timing and in terms of variation, and sharing data is difficult, but we continue to make that better. It's important, simple things like out of hospital school care is difficult because we're dependent on our workforce, and in terms of number of resident doctors per 1,000, Singapore's way ahead. But if we go into the poorer areas of Asia, they're much less well represented. So the word crisis in China, I'm told, means this combination crisis is danger and opportunity. And I think it's a phenomenon. That's how you actually spell it in Chinese. And I think it was Winston Churchill said, and we use this phrase a lot during the COVID pandemic, never waste a good crisis. And I think that is what opportunity and danger coming together. And we know that the Asian century with mechanical support is coming. We know that. Oh, that's odd. There we go. Sorry, I just got an echo of myself. So research is coming, and it's coming big times out of China. The States is still ahead, but this is changing year after year. And we need to understand that today's research is actually tomorrow's treatment. And again, looking sadly at the disruption of the NIH funding, this is what's happening, unfortunately, in the States at the moment. Massive drops, and we hope that stops soon, because we obviously, as a global community, a huge need is required for the States, and they've led for many, many years. So hopefully that can change. But in terms of majority of clinical trials, what's happening here? I'm not really sure why this is giving me a double. Anyway, ECMO volumes we've heard of, and I will move to the end here because I just want to pass over to Christine. But I think Bob, Elso, and the global team that's on the call here shows that we gain much more by growing bridges rather than walls. This is what Elso's done. This is what Bob is famous for. And the dragon has arrived. The horse is on. We're on its back, and we believe that we are stronger together. So to my colleagues across the Asia Pacific that have joined, to our colleagues from the other centres that are just joining, I'd like to say thank you very much. Incredibly impressed. I know that Bob would love to have been part of this. I did say yesterday, the saddest thing about today's wonderful idea, and congratulations to Christine and the team. The only sad thing is that we haven't got Bob Bartlett joining, as he always would. Bartlett, Michigan, great conversation. I've got some things to say. And I think that's what inspires us all. And long may it continue under the great leadership of Christine, Dan, and the team. So with that, I might pause for a question or two, or for some summing up, maybe even a toilet break before we start the next 12 p.m. session. Christine, I'll pass to you.
What a wonderful session, John, and everybody that presented from Asia Pacific. Thank you so much. It was innovative, but also heartfelt. And I think Dr. Bartlett would be really proud and honored. So thank you all so much. I think we'll go really to a break between now and when we'll start with the Southwest Asia and Africa continent. So you can see us moving literally around the world. This was really Nick Barrett's idea, and we have to give him enormous credit for thinking of this as a way to really honor Dr. Bartlett, not only in him being a clinician scientist and showcasing the scientific work around the world, but also these are his friends from everywhere in the world that he visited and welcomed people to Michigan, but also reciprocated and went to everywhere that he was invited. So with that, we'll go to a little break. I'll put a transition slide in here and thank the incredible presenters and moderators from Asia Pacific. John, thank you so much. And I can see some of the names that are still here, Hua Jin, Dr. Hao, Gianluigi, thank you so much, and everyone else that presented this time. Thank you.
Thank you. Just before we go, Sun-Hin Park from Korea has just got a question for Dr. Hao. Dr. Hao, Chia-Chung, I understand that the Chinese government provides significant support for the growth of ECMO cases. In what aspects did the government provide support? I'm not sure whether you want to discuss that online or offline, but would you like to answer that question?
Well, it's hard to answer something because a lot of rules. It's hard to do some collaborations with the international now because the data and the cases are very hard to submit it to the international. So it's hard to say. Yeah, but we still upload the data to the ELSO and without permission. So it's hard to say.
Lovely. Thank you. Alex, I think, was keen to talk to that question. No. No, perhaps not. Good. Okay. Look, 5 minutes to go. Can I congratulate Asia Pacific for ending up perfectly on time? The LATAM this morning was very excited that they ended up on time. They said this is kind of normal for Germany, but definitely not normal for Latinos. This is perfectly normal for us over in the Asia Pacific region. Cheche, Kansamida, Terima kasih, cheers, mate. I think that's as many languages as I can probably manage from the Asia Pacific. But we'll have a 5-minute break, and we look forward to SWAC ELSO and the other regions. And long may Bob's spirit continue. Thank you.
Thanks, everyone.